Okay, Assalamu alaikum wa rahmatullahi wa barakatuh, everyone. Welcome to the GI pathology review. First things first, Eid Mubarak. Hope you guys had a great Eid. I know it's exam season, so probably wasn't the best. Listen, um, I guess this is my first time teaching third years, so let me introduce myself. My name is Abdelrafour Houadne. I am currently an intern, and for the bunch of students who know me, they probably know I'm like interested in ortho, I'm interested in bones. There's not a lot of similarities between, long, beautiful, strong, hard bones and the mushy kind of like organs that are GI. Surprisingly, though, I kind of find GI very therapeutic. Uh, it is a very straightforward and very intuitive block, in my opinion. And I have it like a tradition. Whenever I start a new question bank, whether it's step one or step two, I always start with GI. And hopefully I can kind of like share the same sentiment today as we go through a bunch of pathology topics. Now, obviously, it's a Friday evening, it's Eid season. The vast majority of people tend to prefer to watch these panel sessions recorded. So I kind of took that into consideration in the way how I structured the slides. I'll be going over, we have a lot of content to go through, so I'll be going quite fast. So I do hope the vast majority of you guys do watch it recorded, so you can just pause the video at your own time, try to answer the question, and then we're going to give the answer a bit later on. So you have the opportunity to kind of like think and change the question if you feel like it's the right thing to do, and then see whether you were right or wrong. For anyone who is still attending, thank you. If you have any questions, do let me know. And if you want to drop out for any reason, just please be my guest. So in terms of the way how this session is going to be structured, we're going to go through it organ by organ. My best friend from third year is like, yo, I think you should consider doing it shuffled, which is a really good point because it allows you guys to be a bit more thinking outside the box kind of approach. However, I kind of want this kind of session to be a bit more reviewer friendly, if you can incorporate it within your studying in the days coming up to your exam. So we're gonna go through section by section, organ by organ, and yeah, let's without any further ado, let's just start. And I think it's only fair to start with the esophagus. So we start with the first question. And looking at the key points of this question, you have a 16-year-old boy who's coming in, who's receiving chemotherapy, and he has pain whenever he swallows for the past week. Upon endoscopy, you see 0.5 to 0.8 centimeter mucosal ulcers in the mid to lower esophagus, and they are very round, sharply demarcated, and have an erythematous space. The question is asking you which of the following is likely to produce these findings. Now, whenever you have an immunocompromised patient who's presenting with painful dysphagia or pain during swallowing, the first thing that should come up to your head is infectious esophagitis. Now, there are three main culprits that usually are at the highest of your differential. That's going to be Candida, CMV, and herpes simplex. Now, the big question is, how do I tell them apart? It really is a combination of your endoscopy findings as well as the biopsy findings. The question, Sam, should usually give you both. Now, for CMV, the endoscopy will show very shallow ulcers, and the biopsy would show nuclear and cytoplasmic inclusions within the endothelial cells. Herpes simplex, you'll find very classic punched out ulcers. They are very, very well demarcated. Biopsy will show nuclear inclusions in the epithelial cells. Now, usually I would think it's cruel, if not unethical, to kind of combine these two very niche details within the questions. However, when I was looking at your previous questions, they had some kind of trick questions. So make sure that you're aware that CMV is in the endothelial cells and herpes is in the epithelial cells. Now, the simplest one to identify is Candida, right? Candida is going to have a gray-white pseudomembrane, like in the mouth, in oral thrush, or in the vagina. Biopsy would show obviously the presence of fungi, right? Candida is a fungi. And here's an example of a endoscopy of someone with Candida esophagitis. Notice you have gray-white pseudomembranes, and the biopsy obviously will show a lot of hyphae because, again, Candida is a fungi. Herpes simplex will present the classic punched out ulcers. They're also known as volcano ulcers, the way how they rise above the mucosa and are very sharply demarcated. On biopsy, again, you will have these nuclear inclusions within the epithelial cells, not the endothelial cells. Finally, we have CMV esophagitis. They have very classic appearance on biopsy, and on endoscopy, they are very kind of like shallow. And there's even, for your own like personal interest, deep machine learning technologies that help identify the difference between CMV and herpes simplex purely from the endoscopy findings. So the correct answer to this question, if you chose C, herpes simplex esophagitis, that is the correct answer. So, little pop quiz. Which of the following is true regarding infectious esophagitis? Is it A, herpes virus commonly causes punched out ulcers and nuclear inclusions in the endothelial and stromal cells? Or is it B, CMV causes shallow ulcers and nuclear and cytoplasmic inclusions in epithelial cells? Is it C, candida causes adherent gray-white pseudomembranes covering the esophageal mucosa? Or is it D, candidiasis shows clear-cut ulcers in the epithelial cells? And yeah, this is a trick question. The correct answer is C. Notice how CMV, they place it in the epithelial cell when it should be endothelial, and the opposite is true. Great job. Moving on to question number 2. You have a 57-year-old woman. She's presenting to your clinic with burning epigastric pain after meals. She's been going on for a while. They did an endoscopy and they noticed that she had an erythematous patch in the lower esophagus mucosa. They took a biopsy, and the biopsy showed basal zone hyperplasia, elongation of the lamina propria, and scattered intraepithelial neutrophils with some eosinophils just scattered around. So, whenever a patient comes up to your clinic with a history of GERD symptoms, an erythematous patch, endoscopy, and interesting biopsy findings, the big question that you want to ask is like, what's going on? The central mechanism here is acid is not supposed to go to the esophagus, right? Acid reflux will cause some degree of esophageal inflammation. That's not a good thing. That's a bad thing. Now, initially, on the very acute stages, there's no changes in biopsy. I think the vast majority of us had GERD at some point. Even this past recent Ramadan, you just had a huge shawarma house meal, bayt shawarma, you go to sleep after Fajr, and boom, you have GERD. On a very, very short time frame, it does not have any changes in biopsy. However, the longer or the longer the chronicity of the reflux, sorry for the typo there, the greater the degree of damage and change in the biopsy. So acutely, the biopsy is normal. However, give it some time, and you will notice basal zone hyperplasia, lamina propria elongation, and the infiltration of inflammatory cells like eosinophils and neutrophils. Give it even longer time. Now we're looking at a few years of untreated reflux, and eventually you can even lead to intestinal metaplasia. Now, this combination of basal zone hyperplasia, lamina propria papilla elongation is very characteristic of reflux esophagitis. Now, this is an example of the normal mucosa, the normal histology of the esophagus, right? You have a big, thick epithelium, you got the lamina propria there. Everything looks kind of good. This is how it's supposed to look like. Now, notice, however, in this histology, the papilla, the kind of like the finger-like stuff, are very elongated. You can see a bunch of eosinophils just chilling down there in the lamina propria. Things are not identical to the previous slide here. So this is a good example of reflux esophagitis. These patients will present with a red patch on the endoscopy, and you will find those characteristic basal zone hyperplasia and elongation of papillae in biopsy. So, alternative situation, imagine the patient never got treated. That reflux esophagitis got worse and worse and worse. Eventually, we can run into something called Barrett's esophagus. Now, this is very high yield for both exams and for steps, because this is the conversion of the normal squamous epithelium of the esophagus to the intestinal epithelium. This is an example of intestinal metaplasia. So the epithelium will convert from a squamous epithelium to an intestinal epithelium. And the easiest way to notice that is if you see columnar cells with goblet cells. You're not supposed to be seeing goblet cells in the esophagus. This is an intestinal kind of cell. So here's an example of the normal esophagus on the left. You can see it's very thick. There's a lot of keratin. It's doing its job because it has to, because its food is going to be passing through it every day. In the image on the right, however, is an example of Barrett's esophagus. You can see the presence of goblet cells. The epithelium does not look like the normal esophagus. It looks very intestinal. Here's a gross biopsy from your slides. You can see on the left, the esophagus is nice and red. On the right, however, it's a bit more darker red. It's a bit more velvety. It doesn't look as healthy. It doesn't look as nice. And if you see at the histology slide on the bottom, you have a lot of goblet cells and a lot of intestinal-like tissue, which is a good sign that your esophagus has underwent metaplasia. Now, The real reason why we care so much is that whenever you have metaplasia, wherever it is in the body, it's a pre-malignant condition because give it enough stress with time, it will transform. And in the case of Barrett's, it will transform into something called adenocarcinoma, which is a really bad thing. So here's an example of the same kind of esophagus, and it's getting worse and worse. It's getting uglier. You can still see the goblet cells, which gives you a clue that this is Barrett's, and this is just really ugly. It's becoming a carcinoma in situ. The cells are becoming more erratic. The nuclei look really, really ugly. I'm not even exaggerating. So this patient, if left untreated, will eventually develop adenocarcinoma. And this adenocarcinoma is always going to be very close to the gastroesophageal junction. And these patients will usually present with a history of chronic GERD that probably was either not treated or treated suboptimally. So when we go back to our original question, again, this patient came in, she had burning epigastric pain, endoscopy showed an erythematous patch, and biopsy showed the elongation of the lamina propria and some other signs which are very, very consistent with reflux esophagitis. If you're asking why A is wrong, which is a good other option, it's because in Barrett's, it's not going to appear as this kind of symptoms. It's going to have intestinal metaplasia with the presence of goblet cells, and yeah. So moving on now to question number 3. So this is a 63-year-old man from Birmingham. So that's already one huge L, especially living there for so long. And he's presenting now to your clinic with heartburn and substernal pain that was just going on for the past 25 years, probably untreated. He's now presenting with increased pain and difficulty in swallowing both liquids and solids. So he has some degree of progressive dysphagia. And you do an endoscopy, as you should for these kind of patients, and you will see an ulcerated lower esophageal mass. So patient comes in with dysphagia and malignancy, any red flags, whether it's weight loss, whether it's like history of chronic GERD or old age, is over the age of 60, these are all a lot of red flags. In all these patients, you have to rule out cancer of the esophagus. That's why your next best step is going to be doing an endoscopy. Now, whenever we look at esophageal cancers in general, there are 2 types that we are thinking about. Number 1 is obviously adenocarcinoma, and secondly, we have squamous cell carcinoma. Now, it's sometimes kind of tricky figuring out which one's which, and that's what questions are really going to want you to know. How do you know whether a patient is presenting with squamous cell carcinoma or with adenocarcinoma? Now, to keep it simple, I want you to consider adenocarcinoma as a progression of untreated Barrett's. This is a good example of the metaplasia to dysplasia highway. Patient has intestinal metaplasia, left untreated, the same kind of irritating factor, which is the acid, will eventually pick up a bunch of mutations like TP53 and CDK92A. I totally do not remember this, and I really feel sorry that you guys have to know this. But these kind of genes get picked up in the process, and eventually that metaplasia will transform into dysplasia. And because of that, usually when you do an endoscopy, you'll see various findings. They'll be ulcerated, they'll be exophytic, they'll be fungating, they'll be really, really ugly. And that's usually a clue that you have some sort of malignancy cooking up down there. When you take a biopsy, again, it's the same thing. It's very kind of intestinal-like. You can see a lot of glands, but the nuclei are really messed up. This is a good example of adenocarcinoma of the esophagus. Squamous cell carcinoma, on the other hand, is not related to Barrett's. It's more about exposure to toxic and icky stuff that irritates the esophagus over a chronic long-term process. Now, most good examples, the most common risk factors are going to be alcohol and smoking. Other risk factors, which are important to know, is nitrates in the diet, very hot beverages, which a lot of people in Iran and Mongolia tend to drink. They drink boiling teas, HPV infections, and previous esophageal injury. For example, patients who, for example, drank acid for some reason and they damaged their esophagus, that area of damage could eventually become squamous cell carcinoma. Sorry. Now, another way we can differentiate the two is by location. Squamous cell carcinoma is usually found in the upper 2/3, and adenocarcinoma is usually found on the lower 1/3. And it makes sense because adenocarcinoma is related to Barrett's, and Barrett's is usually found next to the gastroesophageal junction, which is in the lower 1/3 of the esophagus. Looking at the biopsy findings of squamous cell carcinoma is going to be very classic. You have the keratin pearls, you have the intracellular bridges between the different cells. And the moment you see these findings, you know, oh, I'm dealing with a squamous cell carcinoma. Location will kind of help you out a lot also. And you look at the history if the patient has chronic GERD or not. This is a quick summary slide. Again, these patients are going to be presenting with progressive solid food dysphagia. They might also present with like iron deficiency anemia, etc. So again, the adenocarcinoma is in the distal esophagus, the lower 1/3. Squamous cell carcinoma is going to be in the upper 2/3, so the proximal and the mid esophagus. So to the person who chose A, you are absolutely correct. This is a classic case of someone who has esophageal adenocarcinoma. Now, little quick pop quiz for you guys who are attending. So you have a 73-year-old man, he's a bit old, he's been drinking alcohol for many, many years, and now he's presenting with difficulty swallowing, so he has dysphagia, and also a 3 kilogram weight loss, which is now a red flag. He's an old dude, and he's losing weight, looks a lot like malignancy, right? You decide to do an endoscopy, and you find a 3 centimeter ulcerative mass in the mid-esophagus. So this is a gross biopsy of how it looks, blah, blah, blah. You don't need it. All you need is the stuff in red. What do you think the patient has? And yeah, absolutely correct. It is squamous cell carcinoma. It is in the mid and upper esophagus. Patient has no history of GERD, but he's been drinking a lot of alcohol, and we know alcohol is very cytotoxic, so that kind of explains the finding there. Brilliant. Another question. You have another old guy over the age of 60 from Iran. He has difficulty of swallowing for the past year. He's just regurgitating a lot of food. You do an endoscopy. You see this large ulcerated lesion. It's very ugly. You're thinking, oh, this looks like a malignancy. You take a biopsy. You see these infiltrating nests of keratinized cells with distinct cell borders. A lot of messed up nuclei. The question wants you to figure out which of the following is the most likely risk factor. So this is a two-order question. Step number one, you have to identify what he has. Step number two, identify the risk factors that cause what he has. And if you chose C, you are absolutely correct. He's from Iran. They drink a lot of hot teas, which can cause a lot of irritation. Someone in the chat was like, could it be D due to HPV? The question here is very, very kind of like general. It's just infection in general. They're not specifying HPV. If the question did say HPV infection in particular, then yes, I agree. It's a risk factor. But because they kept it very general, they're just speaking about general diet, nitrates. The best kind of like the best kind of answer is going to be diet, especially in areas which are like Iran. If the question was more specific, then yeah, I would go also for like D. So we are now moving to another question. So this is a 23-year-old man. He's presenting to your clinic. He's like, yo, I got food sticking in my chest. It doesn't want to go down. It's really uncomfortable. They get really worse with certain foods like meats or dry bread. But this is only on solid food. He has solid food dysphagia. He has no problems drinking water, coffee, or protein shakes. He tried taking famotidine, which I'll be completely honest with you, I completely forgot what this was, but I had to like do a quick cheeky Google search, and it's like a H2 blocker or something. I don't know, but it's some sort of anti-acid thing. That didn't work, quite obviously. He's presenting now as like, yo, doc, fix me up. And you take a medical history. He's relatively fine. He has a history of asthma, and that's it. So a young male patient presenting with solid food dysphagia, history of atopy, whether it's asthma or allergic rhinitis or atopic dermatitis, wherever it is very, very suspicious for something called eosinophilic esophagitis. Now, another very good clue that you're dealing with eosinophilic esophagitis, if a patient presents with classic GERD symptoms, but they're not responding to antacids. This patient, if he had regular GERD and you gave him that famotidine and he did not improve, that should ring alarm bells in your head. Something is wrong. Something is not normal. In this case, you make a diagnosis of eosinophilic esophagitis when you do an endoscopy and you see more than 15 eosinophils per hyperfluid, per high power field. Now, it's important, it's more than 15 because when we're going through the reflux esophagitis that a lot of people have with GERD, they have scattered eosinophils. They don't have that much. So it has to be 15 or more. If you do endoscopy, and you'll see this more in like step 1 and step 2 questions, they will make mention of something called trachealization of the esophagus, as in the esophagus begins to look like a lot like a trachea, and it's because of these like rings that kind of form within the esophagus, which is another clue that you're dealing with eosinophilic esophagitis. On biopsy, you can see there's a lot of eosinophils. There's red everywhere. That's not supposed to be there. So if you have over 15 eosinophils per high power field view, you can make the diagnosis. And treatment is usually going to be with dietary modification or stuff like that. I'm sure you probably take it into your clinical lecture. So for whoever chose B, the correct answer is yes, it is eosinophilic esophagitis. So we are done with the esophagus. Does anyone have any questions on the esophagus before we move on to the next section, which is the stomach? And I'm gonna use this time to just like drink water, honestly. Okay, so no questions. I'm gonna just move right on. So we have now our first stomach question. It's a 72-year-old guy. He just took a large amount of NSAIDs, and now he's presenting with epigastric pain for the past 2 weeks, and he had an episode of hematemesis. He just vomited out blood. So the question here is asking a biopsy specimen will show which of the following lesions, and they give you a bunch of different causes, a bunch of different factors. So gastritis in general is an umbrella term for any inflammation of the stomach. Again, it makes sense, right? Like hepatitis is any inflammation of the liver. Now, gastritis can either be acute or chronic, but the central idea, the central theme is that you have within all of us a balance between damaging factors and protective factors. Now, obviously, the stomach produces acid. And acid is not selective. Acid just wants to digest. So the stomach kind of like has a lot of protective factors to prevent that, stuff like mucus and bicarb, etc., etc. Now, if for whatever reason you have a decrease in the protective factors or an increase in the damaging factors, you will have some degree of gastritis or some sort of stomach damage. And a lot of very common kind of factors that lead to acute gastritis is going to be alcohol. So someone who drank a lot of alcohol, had like a binge drinking episode, smoking, and NSAIDs. And NSAIDs work by blocking COX inhibitor that will lead to a decrease in prostaglandins. Prostaglandin is a protective factor, so then the balance is shifted and the acid within the stomach will begin to cause problems. Alcohol itself is a cytotoxic, it will cause direct damage, and the same thing for the stomach. So in a patient who's presenting with epigastric pain and hematemesis, and he has some clear factor that initiated all stuff, in our case, it was the patient taking a lot of NSAIDs, that is very characteristic for acute gastritis. On gross morphology, you'll see like a lot of small mini red erosions, and on histology, you'll see a lot of neutrophilic infiltration within the stomach mucosa, right? It's a gastritis, it's inflammation. You're supposed to be seeing some inflammatory cells, and in that case, it's going to be neutrophils. Now, sometimes they'll give you like a lot of differentials. So this is not a classic picture of acute gastritis. We're going to cover this later on. This is an example of someone who's infected with H. pylori, and they may present with very similar symptoms. They'll present with epigastric pain, and maybe they'll have hematemesis. It's something that you should keep in mind. But in this case, where there is no history of H. pylori, and it's very clear that the patient took a large amount of NSAIDs, whoever chose A, that is the correct answer. Moving on to the next question. We have this 54-year-old man. He was previously healthy, but he had like a extensive thermal burn injury, so he got really burnt a lot. And 3 weeks later, he started developing like melanotoc, whatever it is, basically blood stools. Okay, blood pressure is kind of low. It's like 80/40. His hematocrit has declined to 18%. So basically, he is bleeding from somewhere, and he has history of a burn. Now, there's another important concept within stomach pathology, which is going to be stress ulcers, right? By stress, we don't mean like mental stress, which I'm sure you guys are going through. It's more about physiological stress. Physiological stress can cause ulcers in the stomach. And the two important ulcers that you should know, they may be not necessarily super high yield for your exam, but for sure they're very high yield for anyone who's studying for steps or planning to take them in the future. That's going to be Cushing's ulcers and Curling's ulcers. Now, curling's also like a little cheeky mnemonic. Think of curling, right? Curling iron. And curling's ulcers are caused by burns. Cushing's ulcers, however, are caused by an increased ICP. And I put an image of Cushing because he's the neurosurgeon who kind of discovered a lot of this kind of stuff. So you have Cushing's ulcers and you have Cushing's reflex and Cushing's whatever. In the case of Curling's ulcer, due to the burns, you have a lot of like loss of fluids, right? A lot of hypovolemia happens. And this hypovolemia will lead to ischemia of the gastric mucosa. This ischemia is going to lead to Curling ulcers because, again, when you have decreased blood flow to the stomach, blood flow is, by the way, a protective factor. It decreases the amount of bicarb that can reach the stomach, so it's less protected against the damage that is the acid. So Cushing ulcers, on the other hand, are caused by an increase in ICP. It's very important. You guys have had questions before about this. Cushing's ulcers are caused by an increase in the intracranial pressure, which leads to the vagal nerve being like all goofy, and it begins to lead to increased acetylcholine production, and acetylcholine will induce acid hypersecretion. So Curling's ulcers were because of too little protective factors, because of decreased blood flow. And in Cushing's ulcers is the exact opposite. You have too much acid because of the increased intracranial pressure. These are how stress ulcers look morphologically, is like these little pinpoint kind of like black spots. Much to comment, honestly. I'm not a morphology guy. And yeah, this is a question asking you where are they most likely to happen. In this case, the stomach is the correct answer. This patient has a curling ulcer. So move on to another question. Okay, question number 3. Here you have a 51-year-old woman. She's coming into your clinic. She's really tired. She's been tired for the past few months. You take the classic labs. Yeah, she has anemia, iron deficiency. Sorry, but it's not iron deficiency anemia. It's macrocytic anemia. The MCV is above 100. So she has megaloblastic anemia. You take a blood smear. You see a hypersegmented PMNs. Incidentally, the serum gastrin is very, very high. And the question is asking you, antibodies to which of the following are the most likely to be found in this patient? They'll give you a bunch of stuff in order to figure out what's going on. And this is a very nice question. It's a nice question that I'm not, for the people who are attending, I want to see answers for this, because this is going to be very interesting, because this is a tricky question, because I got that question wrong myself. Keep that question in the back of your mind, because let's see if you guys are right. So we got a bunch on D, which is nice. I love that. We move on. Megaloblastic anemia and increased gastrin. This combination should make you instantly think of something called pernicious anemia. Now, let's have a quick recap on how vitamin B12 is absorbed in the body, right? This is some old like preclinical stuff, but it's very important that B12, you have a lot of acid being produced by the parietal cells, and they produce intrinsic factor. Intrinsic factor will then go and bind to B12, and then it will be absorbed in the distal ileum. So we need intrinsic factor that is produced by the parietal cells. In pernicious anemia, you have autoimmune destruction of the parietal cells. You have autoimmune destruction of the parietal cells. So what's going to happen? You have some autoimmune response. The CD4 cells will go and they will start directly attacking the parietal cells. And the B cells will produce a lot of autoantibodies against two things. Against the potassium, the hydrogen potassium ATPase found within parietal cells, as well as intrinsic factor itself. The parietal cells obviously are going to get destroyed. When they get destroyed, they're not able to secrete acid. And we're going to have low levels of acid. The body's going to be like, yo, hold on a second, there's low acid. Increase levels of gastrin. So you're going to have very high levels of gastrin. The decrease in parietal cell mass means not only do we have low acid, we also have low intrinsic factor. And that combination will lead to B12 deficiency, right? Because B12 cannot be absorbed anymore. This is a histology of a normal stomach. Over time, another name for pernicious anemia is atrophic gastritis. You will see that the kind of like, it becomes very red, it becomes very flat. And when you look at the gross morphology, it looks very, very red because you lost a lot of thickness of your stomach epithelium. So you can see the blood vessels in the lamina propria, so it's going to look really, really red. And this is going to be atrophic gastritis. Now, it's very important to know that chronic atrophic gastritis is a bad thing because it will increase the risk of cancer, of stomach cancer. Now, when we go back to this question, the reason why I was like, I really wanted people to choose intrinsic factor is because the actual question was intrinsic factor receptor, which is found in the ileum. So D is wrong. The correct answer is going to be autoantibodies will target the gastric H plus potassium ATPase, and that will lead to low levels of acid. And you will have damage to the parietal cells, so they won't produce the to the intrinsic factor. So that will present with the classic megaloblastic anemia. And if these patients are not treated, they can develop cancer in the future. Thank you so much. So, another question. Question number 4. You have a 59-year-old man. He's presenting with this biopsy here. He had nausea and vomiting for the past 5 months. You do an upper GI endoscopy. You see an erythematous area of mucosa with thickening of the rugal folds. You take the gastric biopsy specimen and you see this kind of like biopsy here. you should be able, this is an example of a spot diagnosis. The moment you see this image, you should know exactly what this patient has. The question is asking you now an extra step. It wants to know the following factors that are most likely responsible for the gastric mucosal pathology, and it gave you a bunch of like virulence factors for a bunch of different types of like microorganisms. The correct answer to this one is this is very classic for H. pylori. You'll have these curved, like comma-shaped bacilli on the surface mucosa layer. They're in the stomach. They're very, very obvious. And you'll also see the presence of Russell bodies. These are like plasmacytes that are filled up with like antibodies, and they're just like chilling in like right around the area. And these Russell bodies are going to be important because they are going to be tied up with one of the complications of untreated H. pylori infections. So keep them in the back of your mind. The virulence factors of H. pylori, there are four very important ones. Obviously, the first one I'm going to go through is urease. Urease breaks down urea in the stomach and converts it into ammonium. This ammonium has a high pH. It's alkaline. It creates this kind of alkaline cloud protecting the H. pylori from the acid contents. You have adhesins, which allow it to bind to the stomach epithelium. You have flagella for movement. And finally, they have a cytotoxin-associated gene A or CAG-A. This is the virulence factor associated with H. pylori. Now, it's important to know, H. pylori causes both gastritis, which we covered previously, and peptic ulcer disease. And as time goes on, untreated H. pylori infection will lead to a lot of stuff. Initially, you will have non-atrophic antral gastritis. Why in the antrum? Because that's where they like to settle, right? This is prime real estate for these bacteria. Over time, however, you will develop something called pangastritis. The entire stomach is inflamed. And as time goes on even longer, you will begin to have multifocal atrophic gastritis, very similar to pernicious anemia. At this point in time, you have decreased acid production. And if that is not treated and time goes on, you're going to have gastric cancer, usually lymphomas. Those Russell bodies over time will be like, you know what? I'm going to change vibes, and they become cancerous or malignant. So that's why I wanted to know. Untreated H. pylori could lead to malignancy. That's also kind of good because if we treat H. pylori, we can reverse some types of malignancies, especially like the maltomas and the lymphomas. Now, how does H. pylori cause ulcers? Again, they basically create that kind of ammonium cloud that tricks those receptors into thinking that the pH is high. So they're like, yo, increase the amount of gastrin. Gastrin goes to the parietal cells. Parietal cells begin to produce a lot of acid. This acid goes into the duodenum and causes ulcerations there. So H. pylori are usually classically associated with duodenal ulcers. Now, peptic ulcer disease is an umbrella term. It corresponds to both gastric and duodenal ulcers. And it's important to know the difference between the two because they present slightly differently. Gastric ulcers get worse after eating. When you eat a big meal, your body produces a lot of acid. That acid irritates the ulcers, and that causes a lot of pain. A lot of these patients stop eating and lose weight. Forbidden weight loss technique. Duodenal ulcers, however, improve with food. When you eat a lot of food, you have a lot of bicarb-rich kind of contents that pass into the duodenum, so they decrease the acidity, increase their pH, and therefore they will improve with food. So these patients may get like pain during nighttime because they're very hungry, or they get a little mild weight gain. Gastric ulcers are like a bit bad because whenever you see a gastric ulcer, you should be kind of scared that it could be malignant, so you want to do a biopsy. However, usually duodenal ulcers are never malignant, so biopsies are not part of your routine management for these patients. Complications of peptic ulcer disease, you want to think of always two: bleeding and perforation. Now, this is a beautiful table from your world. You can see that if the ulcer is in the anterior part of the duodenum and it perforates, it will perforate anteriorly where there's a lot of air and you get perforation. So these patients will present with free air under the diaphragm and they'll have peritonitis. And if you don't do surgery, they will die. On the other hand, if they perforate posteriorly, right posterior to the duodenum is the gastroduodenal artery. That will lead to significant hemorrhage, and they will be presenting with bleeding and severe pain, and that's also really, really bad. So these are some of the complications of duodenal ulcers based on the anatomy. So we took a bit of a tangent. Let's go back to that question. And again, you have a patient who has H. pylori, and they just want you to know the virulence factor. That's going to be cytotoxin-associated gene A, otherwise known as CAG-A. The rest are unrelated and are unrelated to H. pylori. So a little pop quiz for the guys who are attending. You have a 35-year-old guy. He has epigastric pain on and off for the past year. Tends to occur 2 to 3 hours after a meal and is relieved if he takes antacids or eats more food. That's making me think of, sounds a lot like a duodenal ulcer, right? Improves with food. That seems like a duodenal ulcer. He had a bit of weight gain, which is like very relevant to these kind of patients. Anyway, has a urea breath test, is positive. Gastric biopsy shows urease, which means this patient has a chronic H. pylori infection. He takes a 2-week course of antibiotics, does not really improves dramatically, but decides, you know what, I feel better. Why should I keep taking medications? Stops it. And then 3 weeks later, the epigastric pain comes back. If he does not seek treatment, which of the following complications is most likely to develop? So the answer for this question is going to be hematemesis, especially if it's a posterior duodenal ulcer. It will go back and perforate and cause bleeding, severe bleeding. So it'll present with a lot of vomiting of blood because again, he is bleeding. The rest don't really correspond. The pop quiz, you have a 47-year-old woman. She has history of heartburn and dyspepsia. She has sudden onset abdominal pain. And you come and you examine her. She's in severe mid-epigastric pain and she's guarding. So this is signs of peritonitis. It's really not a good sign. You decide to take an X-ray. X-ray shows free air on the diaphragm, and she's taken to surgery because it's a surgical emergency. They find a perforated duodenal ulcer. Which of the following is most likely to have produced these findings? This is a very easy kind of like give me question. Perfect. That is absolutely correct. This is classic for a patient who has peptic ulcer disease caused by a Helicobacter pylori. And like you said, it's most likely an anterior perforation. So, question 5. You got a 52-year-old man. He comes with nausea, with abdominal discomfort after meals. Whenever I hear abdominal discomfort after a meal, or I'm thinking of maybe like vomiting after a meal, I'm like, what's going on here? Something kind of is cooking and it's not a good thing. You do an endoscopy and you see three ovoid nodules in the fundus and the antrum. They are rounded, they are smooth, they are like smooth surfaces. And you take a biopsy and you see irregular, cystically dilated, and elongated foveolar glands. The question is asking you, which of the following treatment strategies is most appropriate for this patient's gastric lesion? It's a bit of a tricky question, honestly, because gastric polyps is one of the lowest yield kind of thing I've ever seen. I've done like I think over 7,000 questions. I've never seen a single gastric polyp, but it's single sides, and I'm going to try to make it relevant for you. This is honestly was mainly for me just because I kind of forgot the stomach anatomy, but the fundus is like the top part and the antrum is the bottom part, and then you just have like the body. Okay, don't judge. Anyway, we're going to be going over now gastric polyps. Now, there are 3 types of polyps that you should be aware of. First one is going to be a fundic gland polyp. Then you have an inflammatory or a hyperplastic polyp. And finally, in red, is an adenomatous polyp. And the color is intentional. The red one is very bad. You can probably guess it's probably pre-malignant. Inflammatory is probably like, it's there. And fundic is probably benign. That's exactly what it is. So you have this kind of fundic gland polyps. They are basically caused by chronic PPI use. They have very high levels of gastrin caused by the chronic suppression of acid, and they cause proliferation of parietal cells. They are completely benign. When you take a biopsy, you have very classic microcysts that are lined with fundic mucosa. These are very dilated glands, and they're lined by parietal cells because, again, this is going to be caused by parietal cell proliferation. And you see in a patient who's been taking chronic PPIs. Do we worry about these? No, because they are not malignant, they're benign, they won't turn into cancer in the future. Whenever you see a polyp, whether it's in the stomach, whether it's in the colon, your biggest concern is, A, will this become cancerous at some point, yes or no? Now, inflammatory or hyperplastic polyps are caused by, like the name suggests, inflammation, chronic inflammation, usually chronic gastritis. The most common cause is going to be an untreated H. pylori infection. And the risk of dysplasia is based on size. I think above 1.5 centimeters, you're getting worried because there's a high chance of it becoming malignant or becoming like dysplastic. So when you take an epithelium, you'll see these are enlarged and dilated foveal epithelium, and these are usually located in the antrum. Notice how in the fungal polyps, they are found in the fundus, whilst here they're located in the antrum. Adenomatous polyps are usually seen in patients who have chronic atrophic gastritis, whether it's a patient who has pernicious anemia or a patient who has severe untreated H. pylori. These patients have, on biopsy, a combination of both intestinal metaplasia and dysplasia. These are very important because they are considered precursors to gastric adenocarcinoma. In fact, 30% of these patients have a concurrent gastric adenocarcinoma somewhere in the stomach. So you got to do a very, very good endoscopy. And this is how they look. Again, very, very ugly biopsy. Look at the cells. The nucleus looks messed up. It looks disgusting. Same thing with the polyp. The polyp does not look nice. Architecture looks really, really bad. I'm waffling, honestly. I don't know what the good architecture looks like, bro. I'm not a pathologist. But I know that the nuclei do not look nice. So to go back to this question, this patient who has these kind of like rounded, smooth surface and irregularly cystically dilated and elongated foveal glands, and he has no history of taking PPIs, I'm thinking this is most likely an inflammatory polyp, and therefore the best kind of treatment for this is, because most of the time it's caused by a untreated H. pylori, I want to give this patient a antibiotic. And we don't do a total gastrectomy because, again, this is not gastric cancer. This is still kind of like, it's less than 1.5 centimeters, so it's probably not going to be malignant. Now, a little pop quiz. You have this 49-year-old woman. She had peptic ulcer disease and she was treated on PPIs. She comes in, does an endoscopy, and you see three circumscribed round, smooth lesions in the gastric body. And you take a biopsy, you see irregular glands that are cystically dilated and flat and lined by flattened parietal and chief cells. There's no inflammation, there's no H. pylori or metaplasia or dysplasia. And to anyone who answered A, you are absolutely correct. This patient has no signs of inflammation, so I can rule out hyperplastic polyps. They don't seem to be really messed up. There's no signs of metaplasia or dysplasia, so I rule out the gastric adenomas. So this is a classic example of a patient with a fundic gland polyp. You, as a doctor, you're just going to reassure the patient and be like, you're absolutely fine. Just don't worry about it. Now we have another question. A lot of questions, guys. This is a 53-year-old woman. She has nausea, vomiting, blah, 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 mid gastric pain. And she has she gets an CT scan and they find gastric outlet obstruction. Something is really blocking the antrum of the stomach. You do an endoscopy and you see this ulcerated 2 by 4 centimeter bulky mass in the antrum. You do a urease test, is positive. And the question is asking you which of the following neoplasms is most likely seen in this biopsy. And they give you a bunch of different stuff. Now, this is kind of like where we dive into gastric cancer. Now, usually these patients are going to present with classic cancer symptoms, the classic weight loss and chronic fatigue and maybe night sweats. And you'll see also a combination with gastric outlet obstruction or early satiety. Either whenever they eat, they vomit and they regurgitate their food, or they eat a little bit and they get really, really full. And this is really not a good sign. I do an endoscopy as a doctor and I will find really bad findings. This is going to be about gastric cancer. Now, there are two very important types of gastric adenocarcinoma that you should be aware of, and it's going to be the diffuse subtype and the intestinal subtype. This is relatively high yield because it does come up in your board exams, it does come up in your steps, and it is important to know the difference between the two. Let's start with the diffuse type. The diffuse type is caused by a loss of E-cadherin expression. This is usually either caused by a CDH1 gene mutation or a DNI methylation, both of them either decreasing the amount of E-cadherin expression. The CDH1 gene mutation kind of completely mutates the E-cadherin, and the DNI methylation process will cause a decrease in the expression. Now, the diffuse type usually is not associated with any of the classic risk factors that we see in patients who have gastric cancer. Usually they have a very characteristic finding, which is signet ring cells. And honestly, my tip to you guys, the moment you see signet ring cells, you know, ala طول, this is a patient with diffuse type gastric cancer. Another finding, which is more of like a gross finding, is linitis plastica, or a leather buttle appearance. Because it's diffuse, it is diffuse across the wall of the stomach. It's not very focal. It's not like an ugly ulcer, like in the intestinal type. No, it is very diffuse. When you look at the biopsy, you can see on the images on the left, this kind of like signet ring cell. The nucleus is pushed to the side by the mucus in the cell. And there's more examples on the right. And you can see in the bottom, the gross morphology, that whitish material all around the stomach wall. That's going to be your linitis plastica. The intestinal type, however, is the one with a bunch of risk factors, right? It's caused by a bunch of different stuff. Could be a patient who has FAP, so yeah, a patient who has a beta-catenin mutation may develop intestinal type, microsatellites, instabilities, hypermethylation of BACs, and hypermethylation of IGFR2. I'm really sorry. I'm gonna be completely honest with you guys. I genuinely do not remember or just have no idea about any of this because ultimately, in real life, it is ridiculously low yield. Did not come in any of the step one or the step two questions. Fortunately, however, you guys are gonna have to learn this because you want to pass GI. But thoughts and prayers. Now, as we said, the intestinal type is associated with a lot of classic risk factors. So pernicious anemia, very important, 15 times higher risk. Chronic atrophic gastritis, like in patients with untreated H. pylori, another high risk. Nitrates and salty food. That's why gastric cancer is very common in Japan. All that sushi with soy sauce has a lot of salt. And finally, H. pylori itself could also lead to an intestinal type. I just realized you guys have been hearing me say H a lot. I'm sorry. I know it's like you guys say H, but it's tough to change this late in the process. Anyway, this is how the biopsy looks like. It looks like a really messed up like intestinal mucosa, and it's very ugly. The nucleus, the nuclei look disgusting. Usually in endoscopy, you see a lot of heaped up margins, a lot of like it's a nasty looking ulcer, very different from the diffuse type. And another nice point is where do they go? Now, this is very nice because it's very high yield. Where do gastric cancers go? And honestly, this is not really only for gastric cancers, it's for any GI malignancy. There are very classical metastatic locations. The first one is Virchow's nodule. This is found in the left clavicular region. You also have Sister Mary Joseph. This is on the umbilical region. And finally, you have something called Krockenberg tumor, which is what we see in the diffuse type. And you will see this like bilateral ovarian malignancy. You take a biopsy and you see a lot of signet ring cells. In fact, this is like a little fun fact for you guys. A lot of times, patients present to the clinic with an ovarian complaint. They get worked up by OB-GYN. OB-GYN takes a biopsy. Then they're like, whoa, that's a signet ring cell. That means it's metastasis. Then they call GI, and GI will go and look for the original location of the gastric cancer. So when we go back to this question, this is a patient who has clear signs of a gastric cancer and a positive urease test. So we know that this is a patient most likely has an adenocarcinoma caused by his untreated H. pylori. Now, a little pop quiz. Got a 67-year-old woman. She's coming with severe nausea, vomiting, early satiety. I am like, oh no. Then I see the 9 kilogram weight loss, and I'm like, oh no, this looks like a gastric malignancy. I order an upper GI endoscopy, obviously, and I'm going to see the entire gastric mucosa is eroded. There's an erythematous cobblestone appearance. Stomach is small and shrunken, and asking you which of the following is the most likely to be found on histological examination of gastric biopsy. And to whoever chose E, you are absolutely correct. It is signet ring cell adenocarcinoma. The clue was in the stomach. The entire stomach is small and shrunken. Means it's the diffuse type of adenocarcinoma, and that is the best answer. If it was like an ulcer or with the heaped up margins, I'm probably thinking more of chronic atrophic gastritis as the better answer choice. Moving on to another question. We have a 52-year-old man. He's presenting with a 4 kilogram weight loss and nausea. I'm like, oh no, something's going up. I do an upper GI endoscopy. I see a 6 centimeter area of irregular, pale fundic mucosa and loss of rugal folds. I take a biopsy. I see a monomorphous infiltrate of lymphoid cells microscopically, which is English for a crap ton of lymphocytes. H. pylori are positive, and I treat the patient with antibiotics, and then there's resolution of his infiltrates. Wherever weird, irregular pale thing disappeared. Questions asking you, what is the most likely diagnosis? This is a good tie-in for the other gastric malignancies. We went through the main one, which is gastric adenocarcinoma. It's the bulk of the topic. But there are other stuff that you should be aware of and keep into the back of your head. These are going to be gastric lymphomas, gastric carcinoid, and GIST, or GIST for short. Carcinoid is going to be very classic. Patient is going to be presenting with carcinoid syndrome, the flushing, the episodic stuff. And you're going to look for it, and you might find it in the stomach. There's a potential location. For the other two, let's dive into it in a little bit more detail. Now, A marginal zone B-cell lymphoma is basically a monoclonal B-cell proliferation. And if it happens in the zones, the MALT zones, we call it a maltoma. This is a very classical kind of like reversible lymphoma if you treat the H. pylori. As we said, the Russell buddies of H. pylori, those like monocytes that are infiltrating and just chilling next to the H. pylori, they're like the besties, basically. Over time, they can become a bit malignant. So they change their vibe. So what we can do is if we treat the H. pylori, they tend to regress and sometimes disappear completely. So that's a good thing. That's a really good thing. GIST is a gastrointestinal stromal tumor. It's a tumor where you have these interstitial cells of Cajal. They are like the pacemakers of the GI. If they begin to proliferate, and usually this happens because of a c-KIT gain of function mutation. So remember, c-KIT for GIST, they will basically proliferate and you have a gastrointestinal tumor. The nice thing about it is because there is a mutation of c-KIT, we can give imatinib, which is a tyrosine kinase inhibitor, and that kind of works. So one, that's kind of interesting because it's the gastric malignancy which has a medical therapy option, which is, and it's not only purely surgical. So when we go back to this question of this patient who has some sort of weird like malignancy-like thing, composed mainly of B lymphocytes that improved after he was treated, this is very, very classical for a patient with a mucosa-associated lymphoid tissue tumor. Okay, so F is the correct answer. Oh, pub quiz. This is from your slides. You can tell because it's like a one-liner. It's not how the question should be. Patient with untreated chronic gastritis and due to H. pylori infection may result, which of the following? Is it GIST? Is it marginal zone B-cell lymphoma, diffuse large B-cell lymphoma, which is an option, by the way. Could be diffuse large B-cell lymphoma. I don't know. What do you guys think? Okay, we got B, and that is absolutely correct. If a patient had a c-KIT mutation, which one will it be? We treat those patients with imatinib. Absolutely correct. It's going to be a GIST, stromal tumor. Okie dokie. We just done with the esophagus. We're done with the stomach. We like a good chunk of the way there. I think that's like the most annoying parts done. I think the rest become very easy and also become a bit high yield. So does anyone have any question from the esophagus or from the stomach? I'm gonna use this time to like top up on my coffee, top up on my water, and wonder why my AC stopped working. That's so sad. I think we all clear. If anyone has any question, you can just post them on the chat. Okie dokie. Now we're moving on to our very first intestinal question. We have this 49-year-old woman. She's presenting with abdominal cramps and diarrhea with 6 stools per day. I mean, that's quite a lot if you guys can think about it. She had a history of similar episodes of self-limited pain and diarrhea, which has been going on for the past 20 years. You do a stool sample, it's positive for blood, so the patient is bleeding somewhere. Colonoscopy shows diffused and uninterrupted mucosal inflammation and superficial ulceration extended from the rectum all the way to the ascending colon, and they give you this kind of like biopsy down there. And they're asking you which of she's at the greatest risk of developing which of the following. This is again a second order question, right? You have a patient who is presenting with, you want to find out what the patient has first, and then you want to find out the complications of said disease. So this is, again, a great way for us to dive into inflammatory bowel disease. Whenever a patient comes to you with chronic episodic bloody diarrhea, I want you to think of IBD because like a single time bloody diarrhea could be an infection, could be just like a bad hamburger, could lead to like Shigella and stuff. But if it's episodic and it's chronic, I'm thinking now of inflammatory bowel disease. Now, there are 2 key components of IBDs. It's either going to be Crohn's or ulcerative colitis. And a lot of your work, a lot of your grind is going to be differentiating the two. That might come up as an SAQ. How do you differentiate between Crohn's and ulcerative colitis? Or this, it's a very common SAQ topic because A, it's very important. B, it's a very high yield thing for all exams, whether it's the boards, the steps, wherever it is. And also, it's a great way to kind of tackle 2 topics in one. Now, the best way for us to differentiate between the two is going to be a combination of location and morphology, okay? The location of the kind of like the damage and the morphology or how it looks in biopsy. Now, honestly, I created this kind of like nifty definition type thing, which is what ulcerative colitis really is. Ulcerative colitis is a continuous, superficial, I completely spelled that wrong, non-granulomatous inflammation of the rectum and the colon. And when we expand onto that definition, we can see a bit more. By continuous, By continuous, I mean there are no skip lesions. There are no areas between the damaged mucosa that is healthy. By superficial, I mean it only targets the mucosa and the submucosa only. By non-granulomatous, there are no granulomas. By Th2, it is mediated by natural killer cells. And by inflammation, obviously, is going to be, again, on biopsy, you won't see any granulomas. There are going to be no skip lesions on endoscopy. And it is only going to target the mucosa and the submucosa. Crohn's disease, on the other hand, is a non-continuous transmural Th1 granulomatous inflammation of the entire GI tract. Classically, they say from mouth to anus. Throughout the entire GI tract, any area is free game. By non-continuous, again, we mean that we have skip lesions. We have areas of normal mucosa between damaged mucosa. By transmural, I mean the entire GI wall is affected. And that's very important because the fact that it's transmural inflammation will have a strong role with the complications. And granulomatous inflammation just basically means these patients will have the presence of non-caseating granulomas. The moment I see non-caseating granulomas, I know this is Crohn's. The moment I see skip lesions, I know this is Crohn's. And this nice slide from your slides kind of like illustrates the same points. See the skip lesions, there are areas between which are healthy. In ulcerative colitis, no, it is continuous. You go from the rectum and you go upwards. There's only one way. Again, the Crohn's is transmural, all the layers are affected, whilst in ulcerative colitis, it is only superficial. So mucosa and submucosa. No lamina propria, nothing else. So how will they present? Ulcerative colitis patients usually will present with episodes of bloody mucoid diarrhea, abdominal pain, and cramps. These patients will also have a red granular appearance in endoscopy. The bladder, the colon wall is going to be very hyperemic, very red, and on colonoscopy, you might find these inflammatory pseudopolyps. This is the regenerating mucosa that bulges into the lumen and creates this like ugly worm-like appearance. It's not nice. It's like day-old spaghetti and not noodles. In biopsies, again, you'll notice that the inflammation is limited to the mucosa and the submucosa only. The lamina propria, the muscularis mucosa is absolutely fine, and you'll see the presence of crypt abscesses. However, in the slides, it mentions that both ulcerative colitis and Crohn's have crypt abscesses, so it's not very specific. Now, there are two very important complications I want you to know. We've already spoken about pseudopolyps. One of the very important complications is toxic megacolon. And the x-rays of toxic megacolon are very, very classic. It's just a huge colon. Another complication is colonic carcinoma. And this is very, very important because that chronic site of inflammation in general, if left untreated, will lead to increased risk of malignancy. But these patients have a bit of a delay. It's 8 to 10 years after diagnosis where they usually begin to develop symptoms. So in order for us to prevent this, after 8 years of IBD, we start routine screening for colon cancer. And of course, the greater the amount of inflammation, the higher the chance. So a patient who has pancolitis, the entire colon is affected, is going to be at a much higher risk than someone who has maybe just like inflammation of the rectum, for example. A Crohn's patient, however, will present with episodes of less bloody diarrhea. They present with abdominal pain, usually right lower quadrant, because the terminal ileum is the most common area affected, and they'll present with a lot of cramps, okay? One interesting thing about Crohn's is it comes up with a lot of complications, which we're going to cover later on. On endoscopy, you will see a lot of cobblestoning. This is the areas of like normal mucosa and abnormal mucosa, creating this kind of like cobblestone appearance. You'll see creeping fat and a lot of these these deep linear ulcers. On biopsy, again, most important thing is finding those non-caseating granulomas. You can see them on the black arrows. And also you'll see a lot of transmural inflammation because the entire wall is affected. This is Crohn's, this is not ulcerative colitis. Complications, the main ones I want you to consider are going to be strictures and fistulas. Why? The entire wall is inflamed. This creates the perfect environment for a fistula. So colovesical fistula, patient's going to come in with repeated UTIs. You do a culture and it's a lot of like GI bacteria like E. coli and Klebsiella, or they'll present with like bubbles in the urine or like nasty smelling urine. Could be a good sign that the patient has a colovesical fistula. Same thing for abscesses, and a lot of times these patients will present with an appendiceal abscess, so they'll mimic acute appendicitis. but upon further workup, you'll find out it's actually an IBD. It's actually Crohn's. This is a very classic table that kind of differentiates the two. You can see again that the Crohn's, it can be anywhere from mouth to anus. The ulcerative colitis is always going to be the rectum and the colon. In microscopy, again, non-caseating granuloma for Crohn's, transmural inflammation. UC has mucosal and submucosal inflammation only, and the presence of those pseudo polyps, whilst the Crohn's have cobblestoning, etc., etc. So when we go back to this question of this patient with, and I mentioned, uninterrupted mucosal inflammation and superficial ulceration, this is a very, very classic example of ulcerative colitis. And again, the most important complication is going to be adenocarcinoma. Now, E may caught people off guard, and if you're one of those people who got caught off guard by E, well, I just want to remind you, ulcerative colitis is associated with primary sclerosing cholangitis, PSC, not PBC. And yeah, fat malabsorption is associated with Crohn's because the terminal ileum can be affected, and pseudomembranous colitis is obviously going to be in patients with C. diff. A little pop quiz. So you got this 26-year-old dude. He has intermittent crippling, cramping, abdominal pain, and low volume diarrhea. You see some occult blood in examination. Now he also has a perirectal fistula. He has many colonoscopy shows many areas of mucosal edema and ulceration, and some areas that appear normal in between. You do a biopsy and you see cryptopsis and a bunch of non-specific things, but also you see a non-caseating granuloma. Which of the following is the most likely finding? Obviously, the moment you see this question, you know it's an IBD question. Your mind is like, is it Crohn's or is it ulcerative colitis? And for anyone who chose B, Crohn's disease, you are absolutely correct. Another question, you have a 30-year-old woman. She has intermittent bouts of lower abdominal pain and this friable mucosa from the rectum all the way up to the ascending colon and a perianal fistula. You do a biopsy, you see acute and chronic mucosal inflammations with focal erosions. All other testing is negative. Which of the following ongoing testing procedures is most useful for long-term follow-up of this woman? We got a bunch of P's. It's kind of heartbreaking. A lot of you guys are too smart for your own good. Correct answer is going to be biopsy screening for this patient, because these patients are going to be at risk in the future of colon cancer. So you want to keep looking there. Someone chose C. I'm going to be honest with you. I have no idea what node 2 is. I have no idea what Saccharomyces are. So I'm going to go back and get back to you and try to give you an answer on why C is wrong. But the answer here is biopsy. So take a little sip of water. This room is getting really hot. So here you have a mother of a 4-year-old child just coming in, and she's like, yo, I noticed blood in his underwear. What is going on, doctor? And you do an examination, you see a rectal mass, and you do a proctoscopy, which is like a colonoscopy, but for the rectum. And you see the smooth surface, pedunculated 1.5 centimeter polyp. Take a biopsy, you see cystically dilated crypts filled with mucin and inflammatory debris, but there is no dysplasia. What is going on? So they found a polyp. And of course, like the vast majority of patients, if they find a polyp, they're always going to be worried and say, yo, is this going to be cancer? And it's a very worrying sign. So your job as a physician is to be able to differentiate benign polyps that are just like being chilling, or versus polyps that could turn into a big serious morbidity. Our job as doctors, again, is to differentiate between those benign and those potentially malignant polyps. So when you look at polyps, you have non-neoplastic polyps and you have those neoplastic polyps. In the non-neoplastic category, you have the hamartomas, the inflammatory, and the hyperplastic. And in the neoplastic polyps, you have the adenomatous. So let's start with the first one. An inflammatory polyp is seen in someone who has chronic inflammation. They are non-neoplastic, and therefore, because it's chronic inflammation, very common in patients who have like IBDs. Hyperplastic polyps are going to be seen in elderly patients, and they are mimickers. They are worrying because you're like, they're an older person, you did a routine colonoscopy, you found a polyp, you want to see, is it caused by malignancy or not? The good news is these are caused by decreased turnover and shedding. People are getting older, turnover is decreasing, and they mimic these sessile serrated adenoma, which is bad. And I'm going to show you later on an example of the biopsy between the two, which is why I tell you they are very bad mimickers. I mean, they're good mimickers, but they're bad for the patients because they're scary. This is how the biopsy looks like. These patients have mature goblet cells and a lot of sessile architecture. The nuclei does not look very bad, but it looks very similar to sessile serrated adenomas, which are bad. This is how they look on colonoscopy. Now, hamartomas polyps, which basically means disorganized growth, by the way, the word hamartomas or hamartoma, they have both stromal and epithelial components, and are usually associated with some polyposis syndromes. The two that I want you to remember are Potts-Jägers or Potts-Jägers. I'm assuming it's a German name. It sounds very German. And juvenile polyps. Peutz-Jeghers is an autosomal dominant disorder. It's a syndrome characterized with multiple hamartomas, both in the GI, and these patients have mucocutaneous hyperpigmentation. These are very easy questions to pick up in exams because I do not know any condition that has mucosal hyperpigmentations or a lot of dark spots in the lips. Now, this is an autosomal dominant disorder. They want you to know it's caused by an LKB1 mutation, but these patients will present with this multiple kind of GI hamartomas. When you take a biopsy, they call it a arborizing, which is tree-like fibromuscular network of connective tissue and muscle. But for me, the easiest way I remember them is by looking for those mucocutaneous hyperpigmentation. Usually in the lips, you see a lot of dark spots, and they'll find a polyp or wherever, or they're bleeding, and you'll be like, oh, this is probably Potts-Jeghers, and it's an autosomal dominant disorder. Juvenile polyps are usually seen in children under the age of 10, and they are usually smooth and pedunculated polyps that are associated with rectal bleeding. Usually seen under the age of 10, and the mothers will come very worried and very concerned. Oh, why is my patient bleeding? Blah, blah, blah. Why is my baby, sorry, not my patient, my baby bleeding? They are going to present microscopically with dilated glands filled with mucus and inflammatory debris. When you look at the rectum, you will see these large, very smooth kind of like polyps. And that concludes our non-neoplastic polyps. On the other hand, we have adenomatous polyps, which are going to be pre-malignant. These are not the good ones. There are three main types based on how they look on the microscope. You have the tubular type, the villus type, and the tubulovillus. Now, looking at them side by side, you'll see that the tubular polyp has a lot of tubes looking. It's like a cross section. It's the most common type, has some degree of dysplasia. You want to probably remove these and keep watching them so they don't turn into cancer. But then you have the villus polyp, which has a much higher risk of malignancy. Yep, sorry. I'm just making sure my internet didn't cut out. So the villus polyp have a much higher risk of malignancy, and especially in polyps over the size of 2 centimeters. So the correct answer is going to be, the correct thing is going to be a villus polyp because it looks really bad. So in this example, in this case, you have this kind of 4-year-old child who's presenting with rectal bleeding and a rectal mass and smooth, kind of like smooth surface pedunculated polyp. The best answer here is going to be a juvenile polyp. Okay, well, pop quiz. Problem is I think I accidentally logged out from my other iPad, so I can't see the answers. I'll ask it anyway. So you have this 70-year-old man who's presenting for a routine health examination. They find a 5-centimeter sessile mass in the upper portion of the descending colon at 50 centimeters from the anal verge. He basically kind of like refuses treatment and kind of goes missing for a bit, comes back later, and now he has 5 kilogram weight loss. He has constipation, he has microcytic anemia, and now there is a 7-centimeter mass in the descending colon. And they're asking him which of the following neoplasms is he most likely to have, and they give you this kind of like biopsy there. So what do you guys think the patient has? Okay, so for anyone who said F, sadly, you're wrong, because he had a villus adenoma in the beginning. The correct answer is adenocarcinoma. Villus adenoma, if left untreated, have a very high chance of turning into adenocarcinoma. And this is exactly what this patient had. Initially, he had a villus adenoma, but because it was left untreated and they have a very high malignancy risk, especially the size at 5 centimeters, that's kind of pretty big. This is going to be an example of a patient with now adenocarcinoma. Moving on to the next question, we have a 19-year-old man who is coming in with this kind of like, he's been picked, his 19-year-old guy picked up by his physician for routine kind of screening in the family, and they found he's carrying some sort of gene mutation. On physical examination, he has blood in his stool, and you do a colonoscopy, and you see something like that. Okay, obviously this is not a colonoscopy; this is a gross specimen, but you see this kind of like this picture down there, And microscopy shows a bunch of these tubular adenomas. And the question is asking you which gene mutation is he most likely to have. And this is a perfect segue to patients who have familial syndromes. This is a patient who got picked up by genetic screening, and there are two important familial syndromes that you should be aware of, and that's going to be familial adenomatous polyposis, or FAP, and Lynch syndrome, otherwise known as HPNCC. The familial adenomatous FAP is an autosomal dominant disorder. Patients have a APC mutation, and that leads to hundreds and hundreds and hundreds of adenomatous polyps in the colon. If these patients are untreated, they have a 100% colorectal cancer transformation rate. So for these patients, it is very important to give them a prophylactic colectomy. At a certain age, you just remove the entire colon. On gross examination, you'll see hundreds and hundreds and hundreds of polyps. On microscopy, you'll see a bunch of different tubular adenomas, as you can see on the image down there. All patients will receive a prophylactic colectomy. Now, there are variants of FAP, and they want you to know two, which is Gardner syndrome and Turco syndrome. Very easy way to remember them. If you have a patient who's presenting with FAP, and they have osteotomas of the mandible, or desmoid and thyroid tumors, that's an example of a Gardner syndrome. If a patient has FAP plus malignant CNS tumors, like medulloblastomas, that's an example of Turco syndrome. So Gardner is FAP plus osteomas, Turco is FAP plus malignant CNS tumors. Now, moving on to the next condition, which is going to be HPNCC or Lynch syndrome. This is an autosomal dominant disorder where you have some sort of mutation in the DNA mismatch repair genes, okay, especially in the microsatellite repair region. These patients are most likely going to have either a MLH1 or a MSH2 mutation. And because of that, they don't have only a higher incidence of colorectal cancer, but they also have a lot of multiple cancer types. So if you have a young patient who's presenting with a few adenomas but has multiple colorectal cancers, especially in like different locations, this is a very classical picture of someone with Lynch syndrome. Contrast that with someone who has FAP. FAP, they have a lot of polyps. Here they have very minimal polyps, but a lot of different locations for colorectal cancer. So in this question of a patient who has FAP, the most likely gene mutation is going to be APC. MLH1 is incorrect because this is more consistent with a patient with Lynch syndrome. A little pop quiz here. Which of the following this is a 44-year-old woman who's presenting now with abdominal distension for the past 6 weeks. She has ascites. You do a paracentesis. You see a lot, 1 liter of cloudy serous fluid. You do a cytological analysis and you see malignant cells consistent with adenocarcinoma. You do some DNA testing and you find MSH2 gene mutation with microsatellite instability. This is all you need to know, but if you want some further tips and help, again, her sister was diagnosed with endometrial cancer, her brother had carcinoma of the stomach, so they have multiple types of cancer, and asking you which of the following conditions is the most likely cause of this patient's symptoms. So again, the best answer here is going to be, like you guys said, D, or Lynch syndrome. Here's another question. You have a 33-year-old man. He's quite young. He comes in for routine health screening. His stool sample comes with blood, so they do a colonoscopy. They see a 6-centimeter ulcerative lesion in the cecum. There are 3 smaller sessile lesions all around. The smaller lesions are reported as sessile serrated adenomas. And the question is asking you which of the following molecular biological events are the most critical in the development of these lesions. So for anyone who mentioned or said B, or defective DNA mismatch repair gene, that is correct. This patient most likely has Lynch syndrome, doesn't have a lot of polyps, but has a lot of these different kind of like malignant type of cancer, colorectal cancer. Ooh, we're nearly done. So this is now the 4th question. We have a 73-year-old man who is now presenting with a change in bowel habits. Whenever you have an old dude with a change in bowel habits, that's usually not a good sign. And he's telling you defecation is more difficult and the caliber of stools have decreased. Another bad sign. You do a physical examination, you ask for a stool sample, another bad sign. Stool is now positive for blood. You do a colonoscopy and you remove, and they're asking you which of the following molecular abnormalities has most likely led to these findings. So this is a good segue or introduction to colon cancer. which is a very important kind of topic because it's not only the third most common cause of cancer, but also the second the second highest cause of cancer-related deaths. Now, the pathogenesis of colon cancer development is via two different pathways. You have an APC beta-catenin pathway and a microsatellite instability pathway. And the very nice thing about it is you can also see just from this slide how both FAP and Lynch syndrome increase the risk of colon cancer. In FAP, we have an APC mutation, right? These patients are at much higher risk of developing colon cancer. In Lynch syndrome, we have mutations in microsatellite instability, explaining why patients who are in Lynch syndrome are at higher risk of developing colon cancer. So this is a nice image from Euro that shows you how the adenoma to carcinoma sequence happens. You have a normal colon, for some reason, wherever, you have an APC inactivation, and then the epithelium becomes hyperproliferative. Then you have a KRAS activation, and you form a very ugly adenoma. And eventually you pick up a P53 inactivation, and that allows the adenoma to become a carcinoma. And this is actually something that has been tested in your exams before. They want you to know that the APC mutation is that first step in the adenoma to adenocarcinoma sequence. Another very interesting kind of topic is the relationship of right-sided versus left-sided colon cancer. And I'm pretty sure that this is kind of previously covered in your clinical lectures, but just because it's relevant to our case, I just wanted to know that the manifestations are going to be different. Right-sided cancers usually tend to be silent bleeders. They're going to be presenting asymptomatically with only iron deficiency anemia that is picked up, and usually when you do colonoscopy, you'll see a very large exophilic mass, okay? In comparison to left-sided cancers, which are more obstructive, patients will come to your clinic telling you, yo, doc, I'm having constipation, I'm having difficulty defecating, and my stool is very narrow, it's like a pencil thin. And this is more because they are circumferential, they wrap around the entire colon, so they're more likely to present with like stool obstruction pathology. So in our case of this patient who's presenting with colorectal cancer, most likely on the left side, the most common reason is because of an acquired APC gene mutation, because that is the first step in the APC adenoma to adenocarcinoma sequence. I'm gonna take a little break here, and I'm gonna try to fix my alternate device so I can see the chat. And I hope that you guys can just give me a little moment to figure out. And if you guys have any questions, I'll try to join the meeting. So we are so close to being nearly done. We're going to move on to now the liver pathology. So let's start with our very first question. We have a 54-year-old woman. She has a long history of chronic hepatitis B infection. She's been feeling a bit weak and tired over the past year. 1 year ago, she had an episode of an upper GI hemorrhage. Now she's coming into your clinic with a very firm nodular liver. Serum albumin levels are around 2.5 and the prothrombin time of around 28 seconds. It's not good, it's elevated. I think it's elevated at least. The question is asking you which of the following physical examination findings are most likely to be present in this woman. So this is a perfect segue into the topic of cirrhosis. Now, I want you to see cirrhosis as like the final destination for a lot of liver pathologies. Think of this as like the equivalent of heart failure in the GI. You can get heart failure through an MI, you can get heart failure through like restrictive cardiomyopathies, through arrhythmias, wherever. It's the same thing with cirrhosis. It's the end result of a lot of pathologies that we're going to see. Cirrhosis is simply fibrosis of the liver. When the liver's parenchyma is replaced by collagen and fibrous tissue, this leads to some degree of liver dysfunction and failure. The liver is not able to do its job. As you guys are soon going to realize, the liver gets a lot of job. Both synthetic, it produces a lot of coagulation factors. It's responsible for the production of albumin. It's responsible for the breakdown of like estrogen. So a lot of the manifestations that you get from cirrhosis is going to be from the liver not doing its job. Now, the exact mechanism behind this fibrosis, it's via the activation of special cells called the stellate or the ito cells. With chronic insult to the liver, whether it's through alcohol or through viral hepatitis or through accumulation of stuff like, copper or iron, these stellate cells will turn into myofibroblasts and produce a lot of collagen, and that will cause fibrosis. Now, this is how it looks on histology. You see these kind of like nodules of regenerating hepatocytes. Dr. Oban kind of calls them regenerating nodules. And when you use a trichrome stain, which turns collagen blue. You see a lot of blue, which is being produced by those cells. So it's a lot of these fibrous bands that are separating the liver into nodules. That explains why the liver will feel very nodular when you're touching it. Now, it's the complications of cirrhosis that cause the main issue, right? It's the actual fibrosis is not that big of a deal. It's the complications of cirrhosis. And there's a lot. You have portal hypertension, which we're going to cover. And portal hypertension itself will lead to varices, it will lead to ascites, and ascites will increase the risk of developing something called spontaneous bacterial peritonitis, which is really bad. Patients who have cirrhosis are at increased risk of hepatocellular carcinoma. Of course, because the liver is failing, you have decreased synthetic functions. The liver is not able to do its job properly. Another complication of that is hepatic encephalopathy, because the amount of ammonium is getting very high. It's going to the brain and kind of like messing things up. So really, it's the complication that causes a lot of problems for us doctors and for the patient, obviously. Now, when you have fibrosis, you cause increased pressure in the portal circulation because you have to drain into the sinusoids of the liver, the actual flow of blood is decreased. So because of that, obviously, there's going to be a backwards increase in the pressure, and you have basically portal hypertension. Now, portal hypertension will lead to both the formation of ascites and the formation of varices, and it does so in different ways. In ascites, the portal hypertension, obviously, when you have an increased amount of blood in the blood vessel, hydrostatic pressure is going to go and overwhelm and go into the circulation. It's going to go into the peritoneum, sorry. Another mechanism of that is that portal hypertension will also lead to increase in the amount of circulating vasodilators, which will lead to, this is probably outside of your scope, but this flanking blood vessels will vasodilate and the systemic pressure will drop. The body will be like, yo, pressure dropping. That's not a good thing. Activate the RAS system. You will increase the amount of sodium and water retention. Now you are in a fluid overload state, which makes it even more fluid to go into the peritoneum. Finally, as we said, the liver is not doing its job properly. It's not synthesizing those proteins. So even the oncotic pressure begins to drop as the amount of albumin drops. So again, you are creating this perfect environment for blood to go from the portal circulation into the peritoneum. In the context of varices, here you have these areas which are known as portocaval or portosystemic anastomosis. These are where the portal circulation meets with the systemic circulation, and they have like a little kind of like flank going on. Most important one for you to remember is esophageal varices. It is the anastomosis of the portal left gastric vein with the systemic esophageal vein. The problem is these areas are not supposed to have a lot of blood flow. They're supposed to be very minimal. In patients who have portal hypertension, a lot of blood will flow towards those areas and they will enlarge and they are very prone to rupture. And that's why a lot of patients with cirrhosis will present with a lot of violent bleeding and hematemesis, which I've seen firsthand in the ER, and it's very, very bad. They bleed a lot and they can easily die from blood loss. From the labs, you can tell that the liver is not doing its job properly because you will see a lot of like elevated prothrombins and low levels of albumin, which means that the liver is not doing its liver is not functioning in the synthetic aspect. Again, as we said previously, another complication is hepatic encephalopathy, and it's caused by the increased levels of ammonium, which are not cleared by the liver, because again, the liver's parenchyma has been replaced by like that NPC collagen. So going back to that question, like someone previously said, the correct answer here is caput medusa, which is another site of portocaval anastomosis, because this patient clearly has cirrhosis. She has history of a variceal hemorrhage a year ago. She has history of chronic hepatitis B, which is what caused her to have cirrhosis. And you can also see the serum albumin levels is low. The prothrombin time is increased because the liver is not creating those coagulation factors. So a little pop quiz here. You have a patient who, it's a very simple question. Patient who has hepatic cirrhosis, which of the following cell types is responsible for this pathological process? Okay, that is absolutely correct. The answer is the stellate cell. The stellate cell of Ito, under the right circumstances, will turn into a myoepithelial cell, sorry, myofibroblast, and just begin to just collagen all over the liver. Moving on to the next question, we have a 57-year-old woman. She's coming in with increasing abdominal enlargement for the past 6 months. I'm thinking, sounds a lot like they mean ascites. However, for the past 2 days, she has developed a high fever Oh no, a patient with ascites and fever. I'm thinking of SBP. They decide to do a physical examination. She's very tender. I'm like, ooh, okay, sounds a lot like SBP. And there is a fluid wave, so she has ascites. Do a paracentesis, sorry, and you can see the cell count is elevated. There's a lot of neutrophils, so this confirms that this patient has spontaneous bacterial peritonitis. However, the question is asking which of the following underlying diseases most commonly accounts for these findings. Oops, I revealed the question too quick. Okay, yeah, the correct answer is actually B. This is the trick question because technically speaking, all the following could lead to cirrhosis. Alpha-1 antitrypsin deficiency is an example of a disease, a metabolic disease. But the question here is very cheeky because it's asking for the most common, and the most common is going to be chronic alcohol abuse. So patients who drink a lot of alcohol, we can see this later on, can develop alcohol cirrhosis. Moving on to another question. Now we have a 30-year-old woman. She comes with a 2-week episode of malaise, which is French for like fatigue. They're just trying to be cheeky. She has fever and jaundice. She had fever and okay. So she had a 2-week episode of malaise, fever, and jaundice 7 years ago. On physical examination, you see needle tracks, which means sounds like someone who's been using IV drugs. You do some serological tests. You see the presence of positive for hepatitis B surface antigen, hepatitis B DNA, and the presence of IgG for anti-hepatitis B core antigen. 2 years later, she goes to the emergency department for hematemesis and ascites. At this point, I'm like, she sounds like she has a very, very classic picture of someone who developed cirrhosis secondary to chronic hepatitis B. Now, another 5 years later, she is presenting with a 5 kilogram weight loss, worsening abdominal pain, and rapid enlargement of the abdomen. Something is not good. She is decompensating. And why is that? This is a perfect segue for us to discuss and meet the viral hepatitis. Obviously, hepatitis E is left out. It's that one kind of like homie who's always left behind, who's always snaking. And this is going to be the various hepatitises. One thing I want you to know, and some kind of like important principles, okay? An acute infection is usually annoying and obviously it's bad, but usually it will self-resolve. There are exceptions to this rule, but usually an acute infection is a resolving problem. A chronic infection, however, is bad because a chronic infection, these patients may be asymptomatic, but they can lead to cirrhosis. And we've seen all the icky stuff that cirrhosis causes. The exceptions to the rule of acute infections usually being benign is hepatitis A in a patient who has a pre-existing liver disease. That hepatitis A could destroy the patient. The patient can die. They can go into liver failure. So if I was a normal healthy patient, hepatitis A is just like whatever. It's like 2 weeks off work and I gotta take a sick leave and maybe do some exams after I come back. But if a patient has a pre-existing liver disease, that's really, really bad. And secondly, hepatitis E in a pregnant woman is also really, really bad. Another kind of like common principle is the presence of an IgM means the patient has an acute infection. IgG means either the patient had an old infection and recovered, or the patient has a chronic infection at the moment. But the moment you see a positive IgM, you know the patient is acutely infected. In terms of histology, the acute viral hepatitis tend to be all very similar. You'll see a lot of lobular lymphocytic inflammation. A lot of those lymphocytes are going to be out there because obviously viral infections tend to attract lymphocytes, and you'll see them just like encircling around the hepatocytes. Hepatitis A is a very classic hepatitis seen in poor areas where there is, because it's transmitted fecal-orally. So if the water is contaminated, or if the food is bad, if you have like oysters that were in like literally shitty water, you may have hepatitis A infection. Usually these patients will present to your clinic with fever, nausea, right upper quadrant pain and tenderness, hepatomegaly and jaundice. The liver is struggling. There's a liver infection. And when you do the serology, the AST and the ALT, they are going to be usually elevated above 1,000. Of course, you can confirm the diagnosis with serology. You'll see the presence of anti-hepatitis A, IgM, wherever. And usually, for the vast majority of patients, this is going to be very self-resolving. Just treat the patient, give them like painkillers and stuff. They'll get better. Again, the only exception is if the patient has a previous liver disease. Hepatitis B is a bit different. The vast majority of patients, around 60%, will recover. Most patients who develop acute hepatitis will recover and will be absolutely fine. They will clear the disease. You will see the presence of serology showing previous infection, but they are okay. However, for a small amount of patients, they lead to what we call persistent infection. And some of these will develop into chronic hepatitis. This is really bad. As we said, chronic infections can lead to cirrhosis, and cirrhosis leads to a lot of complications. Now, a very common way that hepatitis B is tested, both in step 1, sometimes in step 2, and a lot of times in your exams, is by giving you a patient, giving you a bunch of different serology, which is very confusing. I used to hate these kind of questions back in my day, but I'm trying to tell you to figure out what stage the patient is in. If a patient has hepatitis B surface antigen, the patient has an infection. Either it's an acute infection or the patient has a chronic infection. The patient has hepatitis B in his body right now. Hepatitis B envelope antigen is important clinically because it allows us to tell how infective someone is. If someone has high amounts of these antigens, these hepatitis B E antigen, they are very infective. They can easily spread the hepatitis B to others. If you see the presence of anti-HB core antigen, you know the patient was infected. You cannot get the anti-HB core through vaccinations. This is a patient who is infected. And it's also, there's this kind of like phase, the window phase, where like a lot of those serologies disappear. This is always going to be there. So the moment you see a patient who has anti-HBC core, IgM, you know that this is a patient in acute infection. If you see IgG, you can't really tell. But you know that he never picked it up from a vaccination because you cannot get the core antigen antibodies through vaccination. The surface antibody is less useful. It just basically could be seen in previous infections or patients who have who have been vaccinated before. And usually we just use this to determine whether someone is basically immune to hepatitis B or not. And you will notice you guys are third year, so inshallah in a few months you guys are going to be doing a lot of serologies because you're going to be starting fourth year, and they want to make sure that you don't have hepatitis B. So they will be looking at your surface antibodies. So if you see that you have anti-hepatitis B surface antibodies and no anti-HBC, you know that this is probably from the vaccinations. If you see a core antigen, that means you were infected with hepatitis B before at some point, and you could have been asymptomatic. Moving on to how they look in histology, you will again see two very characteristic findings in patients who have chronic hepatitis B. First one is going to be these ground glass appearance of hepatocytes. These hepatocytes are filled with antibodies. These antibodies give it that characteristic ground glass inclusions. Also, you may find these Councilman bodies. Councilman bodies are these really pink, it's like fuchsia color, and it's basically just a dead or a hepatocyte that is undergoing apoptosis. Now, sometimes it's a bit hard, and you might get confused between Mallory bodies and Councilman bodies. Just remember, Councilman bodies is not going to be seen in that; it's going to be seen in viral hepatitis. But look at the question stem more. Focus more on the question stem, and this is more of a kind of a confirmatory finding that someone has chronic hepatitis. Where do you get hepatitis B? Very similar to hepatitis C. Usually you get it from IV drug use or through sex with someone who is infected. That's why it's very important for us to look at those hepatitis B E antigen so we can tell patients, oh, by the way, be careful. You can spread the hepatitis B to your partner during sex. So maybe like abstain for a certain period of time until your body basically clears it. Now, hepatitis C it's very sad because it has a very, very high rate of chronic infections, unlike hepatitis B. A lot of these patients who have chronic hepatitis C tend to develop cirrhosis, and also sadly, there's no vaccine for hepatitis C, so it's really a nasty virus. Again, you'll see a lot of lymphoid aggregates within these patients, so you'll see a lot of lymphocytes around. And again, you can see these histopathology images from your slides. And honestly, that's basically it. Chronic hepatitis C can easily lead to cirrhosis, and you'll see a lot of questions where a patient had chronic hepatitis C. We've seen one of them, by the way, untreated, and obviously it turned into cirrhosis later on. Now, hepatitis D is interesting. It cannot happen on its own. It needs the help of a hepatitis B infected cell. It cannot get in. So there are two scenarios of someone who's infected with hepatitis D. Either it's a co-infection, so it's happening at the same time. These are usually very mild and they self-resolve. However, some people have hepatitis D super infection on someone who's a chronic hep B carrier. When this happens, that increases the chance that person will become into a chronic hepatitis state. So if it's a co-infection, that's all right. If it's a super infection, that's really bad. Hepatitis E, again, is very self-limiting. Again, it's also caused by fecal-oral contamination. The only thing that you should remember is if the patient is pregnant, this could be very fatal, and these poor mothers would present with fulminant liver failure because of hepatitis E. Now, a complication of untreated chronic viral hepatitis is hepatocellular carcinoma. And as we said previously, one of the complications of cirrhosis is hepatocellular carcinoma. Now, hepatocellular carcinoma can be seen in cirrhosis from all etiologies, could be directly from chronic hepatitis B without cirrhosis, or environmental toxins like aflatoxin, which is seen in some countries who farm a lot of corn. Hepatocellular carcinoma is usually asymptomatic. However, it can present with abdominal pain and weight loss and all that kind of like jazz, which is associated with malignancy. But very important, the ascites is going to be different. It's not going to be straw-colored like in ascites seen in cirrhosis. It's going to be bloody. When you do your when you take a paracentesis, you will see malignant cells in the microscope. Now, when I have hepatocellular carcinoma, I can confirm it with imaging. Obviously, I'm going to do a CT scan. I'm going to do all those imaging, but also the alpha fetoprotein is elevated in patients with hepatocellular carcinoma. In the imaging, again, you will see just like really messed up hepatocytes. The nuclei looks really ugly. Again, it just does not look like a normal liver. And usually, again, this is more of a pathology level kind of question. Inside of the gross, you will see usually one large green nodule and then some smaller satellite ones. If you see a liver with multiple equal size kind of like masses, don't forget that the most common cause of liver cancer is going to be metastasis. Hepatocellular carcinoma is not the most common cause of liver cancer. It could be metastasis from the lungs, from the GI, or most commonly from the colon cancer, because you have a portal circulation between the colon and the liver. So going back to this question of this patient who had chronic hepatitis B, now she's developing increasing weight loss and worsening abdominal pain and rapid enlargement of the abdomen. The correct answer is going to be increase in the serum AFP because this patient has hepatocellular carcinoma. Now, if you chose an increase in the prothrombin time, that would make sense if you were thinking of cirrhosis, which, like you said, it's a valid choice. This patient could have developed a cirrhosis. It's reasonable, but there's not a lot of clues in this question sent to show that. Okay, it could be, it could not be, but this kind of 5 kilogram weight loss, worsening abdominal pain, and rapid enlargement, this is more consistent with the patient who developed now hepatocellular carcinoma. So the most important thing is going to be alpha fetoprotein. I hope this makes sense. So a little pop quiz here. A 42-year-old man, blah, 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 a bunch of information. What they just want to know, this patient is positive for IgM, anti-hepatitis A, and he's negative for hepatitis C and hepatitis B and all that kind of stuff. They want to know which of the following outcomes is most likely to occur in this man. Phenomenal. Absolutely phenomenal. If that's if you chose B, obviously. So hepatitis A is very nice. Obviously, it's not very nice acutely, but usually it's cleared. It's self-resolving. I'm gonna stick with that. Chronic active hepatitis, that's probably more with maybe like hepatitis C. Fulminant hepatitis, that's the correct answer if the mother was pregnant and she was infected with hepatitis A. And hepatocellular carcinoma is especially associated with chronic hepatitis B infection. Yep, just making sure. So we move on to a third question, and I think it may potentially be it's the second. It's a nice question. Don't worry. This is a 31-year-old woman. She comes to your clinic. She's been like, "Yo, listen, I've been feeling very weak and very fatigued and very tired for the past 4 months." They give you an ASC of around 67, an ALT of around 91, so mildly elevated, nothing too high. The alkaline phosphatase is also kind of normal. Test results show ANA positive, anti-liver kidney microsome 1 positive, and most importantly, anti-smooth muscle antibody positive. You do a biopsy, you see minimal portal mononuclear cell infiltrates, and they're asking you which of the following is the most likely diagnosis. Now, this is very interesting. A woman just presenting with fatigue, mildly elevated LFTs, normal alkaline phosphatase, but most importantly, and this is honestly, you can get the question right just from this one word, anti-smooth muscle antibodies. The moment you see anti-smooth muscle, you know this is autoimmune hepatitis. Sometimes it is asymptomatic. A lot of times, actually, it's asymptomatic. You are going to your primary healthcare physician, and they're like, "Yo, your LFTs are kind of going up. What's going on?" Sometimes, if it's symptomatic, it's going to be very non-specific. Fatigue, anorexia, nausea, jaundice, very non-specific findings. And a lot of times, the patient will have some other autoimmune disorder, whether it's like autoimmune thyroiditis or etc. The lab findings are going to be very hepatocellular. AC and ALT will be elevated, and the alkaline phosphatase is going to be usually normal. And the most important thing is you're going to find that this anti-smooth muscle positive. In terms of histology, you'll see a lot of plasma cells and lymphocytes around the portal tract. This is portal tract inflammation. And it makes sense because obviously this is autoimmune and you have a lot of B cells and a lot of lymphocytes going there, getting a bit confused and attacking the liver. Let's change things up a little bit. Let's give you another woman with fatigue, but this time she has a cholestatic picture. So alkaline phosphatase is elevated, the bilirubin levels is elevated. She has a bit of jaundice. She's itching a lot, and she has positive anti-mitochondrial antibodies. This is very characteristic for primary biliary cholangitis. Now, primary biliary cholangitis is an autoimmune destruction of the intrahepatic bile ducts. This usually, again, affects middle-aged women. They'll present with fatigue and itchy skin. That itchy skin is because of the increased levels of those bilirubin levels. You may even see like cutaneous xanthomas and xanthelasmas because they have an increase in cholesterol. You will do labs and you'll see a cholestatic pattern of liver injury. So increased levels of alkaline phosphatase and mildly elevated increases of aminotransferases. And this is a very classic picture of primary biliary cholangitis. So for whoever chose autoimmune hepatitis for this question, you are absolutely correct. She has anti-smooth muscle. If this question was changed and they substituted like anti-mitochondrial, you know that this is going to be primary biliary cirrhosis. Going to another question here. Okay, this is the biopsy. It's a 38-year-old man who is feeling acutely ill. He's coming to the ER with nausea, upper abdominal pain, jaundice after drinking a heavy night over the weekend. Maybe he watched the Hilal game and he's happy that they won. He's drunk out of his mind. Upon examination, he has a right upper quadrant tenderness. WBCs are elevated. AST is elevated. It's like 542, 393, and they give you this liver biopsy, and you see this like pink stuff on the cells, and it's just like, what is going on? And asking you, what does blood have? Or what's going on in his liver? This is, again, a nice way to talk about alcoholic liver disease. And again, alcoholic liver disease is not a singular disease. It's, again, a spectrum. And you could have alcoholic hepatitis, which is an acute infection related to drinking a lot of alcohol. You have alcoholic steatosis, which is the accumulation of fat in the liver because of the way how alcohol is metabolized. And finally, which is like the final, like worst one, is alcoholic cirrhosis, which is going to be, again, I had a question of this earlier. A patient who's presenting with a history of chronic alcohol drinking, and now he's presenting with cirrhosis. It's really not nice. Again, alcoholic hepatitis is an acute condition. Patients will present like the previous patient with jaundice and fever and right upper quadrant pain and tenderness, and AC and ALT will be elevated, not crazy elevated, not above 1,000, but at least they'll be in the hundreds. And this very nice clue, usually look at the AST to ALT ratio, usually it's over 2. If you want to see more clues, an increase in the GGT means homie was drinking. He could be denying in the ER, I haven't taken a single drink. But if the GGT is elevated, you know this is a very good clue that the patient has actually been drinking. Those pinkish stuff that we saw were something called Mallory buddies. Like the alcohol kind of like messes up with some intermediate filaments and they begin to accumulate. You can also see the ballooned hepatocytes that look really big. On the images on the right, you see a lot of fat droplets, those little white spaces. This is an example of alcoholic steatosis. Again, another clue that this patient drinks alcohol a lot. Again, this is another image. You can see how the liver has been replaced with a lot of fat droplets. This is the accumulation of fat within the liver. So the correct answer for this is Mallory Dank buddies or Mallory buddies, and they are found in patients with alcoholic hepatitis. Viral inclusions are a very common mistake that people choose. And again, viral buddies are going to be different. This is going to be a patient with chronic hepatitis, and they will have this kind of like ground glass appearance. And councilman buddies, which are going to be these cells, which are very pink. Okay, and they look like they're blushing, basically. Think of like a councilman who keeps blushing. There's another question. This is honestly one of my favorite diseases because I love when they come up in steps. It's nice. It's an easy mark. You're getting hammered by a tough block, and you see this and you're like, I like this. This is the biopsy they give you, and you have a 44-year-old man who comes in with a bit of arthritis. His serum glucose is a bit elevated, kind of sus, right? A bit like, sounds a bit like diabetes, right? Very high levels of ferritin. Whoa. Has some pulmonary edema, some cardiomegaly, and honestly, really, this liver biopsy tells you everything. The moment you hear Prussian blue stain, you want to think of iron. Right? Prussian blue stain, think of iron. This is a stain that stains iron. And there's a lot of iron. The question doesn't want to know the diagnosis, however, it wants to know the therapy. So again, this is a nice time for us to sit down and discuss about metabolic liver diseases. Now, there are three metabolic liver diseases. I'm not going to discuss alpha-1 antitrypsin deficiency because that's technically a clinical lecture, but they're all very similar. They all lead to accumulation of stuff in the liver. And when that stuff accumulates in the liver, it causes cirrhosis long term. And as our job as physicians, our jobs as clinicians is to prevent that from happening. We want to prevent the patient from accumulating stuff in the liver so they don't get cirrhosis. Because once cirrhosis develops, by the way, the only treatment is going to be a liver transplant. There are three metabolic liver diseases: alpha-1 antitrypsin deficiency, Wilson's disease, and hereditary hemochromatosis. When I use this image, honestly, I thought about this meme and I was like, you know what? That's a great way to create like a mnemonic-friendly things. And if you're a Harry Potter fans, I am really sorry. I'm probably gonna be this like massacring your favorite show. Let's start with our homeboy here. Again, his hair looks a bit coppery, if I say so myself. And that's a good reminder that Wilson's is all about abnormal copper metabolism. Copper is an orphan. I would like to keep some because we need copper, obviously. And the rest we like to just dump it into the bile and just excrete it out of the body. Now, the most important protein that allows for all this to happen is a little molecule called ATP7B in the hepatocyte. Now, ATP7B does two things. It takes that dietary copper and it packages it into a molecule of apoceruloplasmin to create ceruloplasmin. Ceruloplasmin is badass because ceruloplasmin can go into the bloodstream. And then you have like a transporter, a little Uber for copper to go into the rest of the body to be used. ATP7B is also important because it allows copper to be loaded into the bile and excreted in the poop to the rest of the body, therefore maintaining homeostasis. So as we said, ATP7B is super duper important. In Wilson's, you have an autosomal recessive disorder with a mutation in the ATP7B. So it's not able to do its job. It's not able to package copper into apoceruloplasmin. So you won't have normal levels of ceruloplasmin. And also because it's mutated, it does not allow for the copper to leave. So what happens? The copper is stuck in the liver cell. It's stuck, it's stuck, it's stuck. Eventually, it causes too much damage and it destroys the hepatocyte and it spills. When it spills, you have free copper in the bloodstream. And you don't want free copper because free copper loves to accumulate. It accumulates in the heart, it accumulates in the eyes, it accumulates in a lot of tissues. And because it accumulates in a lot of tissues, this is a good example of a systemic disease. It's not going to target a single organ system. And that's why they love to test this concept in UWorld. They love to test this question in step 1 and step 2 because they can bring it up in the GI block, they can bring it in the ophthalmology block, they can even bring it in the heart or the neurology blocks. Obviously, we are taking GI. So cirrhosis is the most important thing. You'll see a youngest patient who's maybe 30 or 40 with cirrhosis. That's not normal. Cirrhosis is usually seen in like 50s and 60s, right? Also in the eyes, they accumulate and they have a very characteristic Kaiser-Fleischer rings. In the heart, they lead to restrictive cardiomyopathy, and the basal ganglia, they lead to neuropsychiatric symptoms like tremors and chorea and all that nasty stuff. This is how it looks. You do a slit lamp examination. You see that copper ring around the eye. That's a very good example of someone who has Wilson. That's a Kaiser-Fleischer ring. In terms of the labs, if you see low ceruloplasmin or increased serum copper, it's an automatic, this patient has Wilson's. Our treatment option is penicillamine. This is a copper chelator. It binds to copper and allows it to get excreted out of the body. And again, this is important because our job as physicians is to prevent progression of the disease. Moving on to our next disease, and this is obviously Harry, and Harry sounds a lot like HH, so hereditary hemochromatosis. And just imagine, for the sake of argument, that his wand was actually made up of pure iron. That is kind of a good mnemonic to make you remember that HH, or hereditary hemochromatosis, is a disorder of abnormal iron metabolism. Here we have too much iron absorption. Now, there's one very important kind of concept to know. Our body, unlike with copper, we do not have a system in place to excrete iron. If I have a patient with thalassemia or sickle cell, and I give him a blood transfusion every month, he is going to go into iron overload. There's going to come a moment in time where he has too much iron because you are bypassing the body's system of controlling iron absorption. And how does the body do that? It's because the control of iron levels in the body is based on how much iron is being absorbed. You have a sensor in the hepatocyte. This sensor works to detect the levels of iron. In hereditary hemochromatosis, the sensor doesn't work, so the body keeps thinking that the iron levels are low and keeps absorbing. This is a nice diagram from UWorld, okay? You have a patient, you have that kind of like sensor, and when the levels of iron are low, It basically decreases the levels of hepcidin. When hepcidin doesn't work, you have an increase in iron absorption from ferroportin or DMT1. You don't have to know this, but just know when there's less hepcidin being released, there's going to be more absorption of iron. In patients with hereditary hemochromatosis, they have a mutation. That HFE gene is mutated, so the body's sensor is abnormal, so there's this constant iron absorption. When you have too much iron absorption, it begins to accumulate all over the body because the body has no way to get rid of it. And again, it's a systemic diseases. It depends. The symptoms depend on where they accumulate. So again, in the GI you have cirrhosis. In the pancreas you have diabetes mellitus, and in the skin you have hyperpigmentation. Now that's why they have a very classic triad of cirrhosis, diabetes, and bronze skin. And they call this bronze diabetes because of the hyperpigmentation. The labs will show elevated ferritin. Same way as how Wilson's show low ceruloplasmin, labs will show elevated ferritin. And you know that's it. It's game over. If you use a Prussian blue stain, which stains iron blue, you will see so much blue in the liver. This is not normal. This is, again, confirmatory proof the patient has hereditary hemochromatosis. Usually we don't do biopsies because these are invasive and annoying and stuff. And the exact mutation that is responsible is C282Y mutation. So C282Y mutation, if that is kind of picked up, that is an instant confirmation. And the treatment of these patients is phlebotomy. Now here's a very interesting point. Women who have hereditary hemochromatosis develop symptoms much later than men. That's because the monthly menstrual cycle leads to constant blood loss. So that kind of decreases the amount of iron accumulating. So in a way to mimic this process, the treatment of hemochromatosis is via phlebotomy. We continuously keep drawing blood to keep those ferritin levels low. So going back to our previous question, if you chose phlebotomy, the answer is correct. This patient has a classic picture of hemochromatosis. You can even see that the increased levels of serum glucose is probably a sign that the iron is accumulating in his pancreas and he's developing diabetes. So a pop quiz here. A 19-year-old woman, she has a tremor at rest, which is being annoying, and then it kind of gets worse. She begins to have paranoid ideation and auditory hallucinations, and then she goes to a psych, and they diagnose her as acute psychosis. But when the psych doctor is doing an examination, he sees jaundice, scleral icterus, and he does a slit lamp examination, and they see corneal flesherings. The bilirubin is elevated. It's direct hyperbiliary. The AST and the ALT is mildly elevated. Seems like her psychiatric symptoms could be caused by something biological. So which of the following is most likely to be reported in this patient? So whoever chose B, I'm sorry to tell you this, but you're absolutely correct. This is a very classic picture of a patient with Wilson. They have very low levels of ceruloplasmin. Why? Because again, you have a defect in the ATP7B gene. And again, does anyone have any questions on the liver? We are so close to finishing. Now we're going to dive into the pancreas. Okay, so I'm going to dive right in. We have a bit of a big question here. We have a 38-year-old woman. She has history of gallbladder disease, and suddenly now she's coming into the ER with sudden onset of severe mid-abdominal pain. Everything kind of looks okay. You do an abdominal CT scan, and it shows decreased attenuation with fluid density involving the pancreas. Question is, which of the following serum laboratory tests is most useful for diagnosis? One thing I want to comment on just on the side, notice how the first thing they did was a X-ray. Why? X-rays are quick, and you want to rule out free air. If hypothetically the patient did have free air under the diaphragm, what's now your differential? What do you think is happening if the patient suddenly has severe sudden pain and there's free air on X-rays? If you thought of a perforated ulcer, you are absolutely correct. Perforation of an ulcer, oh, absolutely, yeah, wonderful, thank you. So, without getting sidetracked, let's see what's going on with this patient. So, any patient who comes to the ER with sudden onset epigastric pain, usually radiating to the back, you should be suspicious, or acute pancreatitis should be in your differential. Now, the usual diagnostic criteria, you need to have 2 out of these 3. The patient must have epigastric pain, and then elevated amylase or lipase levels, and a CT scan showing signs of pancreatitis. Because the CT scan takes time and it's expensive, usually if we have two of those, they're perfect. So usually what happens, what I've seen in the ER, patient comes in with sudden epigastric pain radiating to the back. You check the amylase and lipase levels. If it's elevated, there's no need to do a CT. But usually, again, they might give you any of these combinations. Just know 2 out of these 3, and now you should be thinking of acute pancreatitis. On CT, you'll see a lot of like edema around the pancreas, like fat surrounding, and it just shows you that something is off with the pancreas. Now, the most common causes are going to be alcohol or gallstone obstruction. Here in Saudi Arabia, obviously, because there's not a lot of people drink, gallstones are more common. But usually, if you look at it from an international perspective, it's like 40% for both. There are obviously other causes. There are, for example, hypertriglyceridemia for patients who have those dyslipidemic disorders that could trigger acute pancreatitis. Some drugs can lead to that, like loop diuretics and thiazide diuretics, some infections. In kids, the most common cause is trauma. So usually kids will be riding a bike and they will slip and they will hit the abdomen, the epigastric region with the handlebars. So they have a handlebar injury and they develop pancreatitis, or sometimes could be caused by us, doctors, maybe post-ERCP, and they may develop an acute pancreatitis. Most important thing is you will see again acute pain and elevations on the lipase and the amylase. Obviously, the lipase being better, it's more specific. Amylase could be elevated in other stuff. And if you look at the biopsy, you'll see a lot of fat necrosis. There's a lot of fat necrosis that happens because the pancreas has a lot of those pancreatic enzymes that digest fat. Sometimes they digest fats around the pancreas. However, if you have a young child who doesn't have trauma, comes in with repeated episodes of acute pancreatitis and tells you, oh, my dad has the same thing. He had the same thing throughout his life. And my grandpa had the same thing. He had the same thing throughout his life. You are thinking of now some sort of hereditary pancreatitis syndrome. And this too you need to know. And I'm so sorry that it's bad. But there have been like 2 questions asked in the previous questions. So you have either it can be caused by a autosomal dominant mutation of the PRSS1 gene, or an autosomal recessive mutation of the SPINK1 gene. The PRSS1 gene codes for trypsinogen. So when that mutation happens, think of it as a gain of function mutation, which leads to too much trypsin. So there's a hyperactivation of trypsin. In the SPINK1 form, you have a loss of function mutation of a trypsin inhibitor. So if you lose the trypsin inhibitor, you'll have high levels of trypsin. And again, both of these will lead to acute pancreatitis. Now, sometimes they'll give you both of these in the questions then. So how do you tell which one's which? The key is to look at the inheritance pattern. If the grandfather and the father both have it, that means probably it is going to be autosomal dominant, so think of the PRSS1. If, however, it skips a generation, father was fine, maybe his grandfather had it, but he's good, his mom is good, then it's more of an autosomal recessive pattern, and think of the SPINK1 gene. Complications of pancreatitis, regardless of the cause, usually include a pseudocyst being formed later, a few weeks down the line. So patient will have acute pancreatitis. Again, don't forget, guys, treatment of acute pancreatitis is usually supportive. You just give them some good pain relief, you give them IV fluids, and you just watch and wait. But imagine a patient comes back a few weeks later and is like, yo, like I feel like I get full very quickly, I'm vomiting and blah, blah, blah. And do a CT scan and you see this huge mass and it's really well defined and there's a thick capsule. This is a good example of a pancreatic pseudocyst that would just like place a needle and just drain that bad boy, and they usually tend to be okay. Now, what about chronic pancreatitis? We've been speaking a lot about acute. What about chronic? Now, in patients who have repeated episodes of acute pancreatitis and then they start developing chronic pain and signs of pancreatic insufficiency, which is stuff like maybe diabetes, maybe they'll have a lot of like fatty stools because of that steatorrhea. As we said, if you're losing pancreatic enzymes, whether it's through chronic pancreatitis, whether it's through maybe cystic fibrosis, these patients will have these kind of like fatty, very big stools that just like block your toilets. This is usually more consistent with chronic pancreatitis. Usually, an X-ray or a CT will show these calcifications. Whenever you see a small atrophic pancreas with calcifications, you should think immediately of chronic pancreatitis. So when we go back to this question asking you which of the following, if it's elevated, will prove that this patient has pancreatitis, the answer is amylase. Because amylase and lipase are both elevated in acute pancreatitis. So, a little pop quiz for you guys who are attending. You have an 11-year-old boy. He comes with multiple bouts of severe abdominal pain. Tells you that his father and grandfather have the same symptoms. And again, you do an examination. He has diffuse pain and serum amylase is elevated to 3,000. So, patient clearly is coming with acute pancreatitis. Question is asking you which of the following is the mutation he most likely has. Whoever chose C, I am incredibly proud of you, honestly. Okay, because I'll be honest with you, I kind of had like a brain fart when I was solving it the first time, and I was, oh, Spink one. Spink one sounds nicer, like Loki. Correct answer, however, is PRSS, and that's because of the inheritance. If both the father and the grandfather had it, it is an autosomal dominant disease. Okay, good job. Moving on to the next question. You have a 73-year-old woman. She's coming onto your clinic. She's been losing a lot of weight, 10 kg in 3 months. She looks very, very yellow. She's ecteric and she has this constant epigastric pain and bloating and diarrhea. And she tells you like this pain is worse at night. It's just miserable. You just do some examinations. Nothing really comes up. And you see that the bilirubin concentration is elevated to 11.6 and direct bilirubin is 7.5. This is an example of a direct hyperbiliary. What's going on? Any patient who comes with constant epigastric pain and jaundice that and alarm signs, like they're old, or they have weight loss, or whatever, that is very, very scary and very, very sad for pancreatic cancer. So you have to rule that out. Now, pancreatic cancer or pancreatic adenocarcinoma has a lot of risk factors. Smoking is very important. Hereditary pancreatitis is very important. Patients who have chronic pancreatitis are very common. Surprisingly, alcohol has not been shown to be a risk factor. Even though alcohol can cause pancreatitis, it has not been shown to cause pancreatic carcinoma. However, these patients will present mainly with abdominal pain or back pain and jaundice. Now, this is very important. Jaundice is specifically more associated if the carcinoma is on the head of the pancreas, because there it'll be able to compress the biliary tree. Other clues is migratory superficial thrombophlebitis or Trousseau syndrome. You have this like thrombophlebitis in the arm, then the other arm, and the leg, it keeps moving around. This is another clue. But then you are suspecting pancreatic cancer, so what you do is you do a CT scan and you'll see your diagnosis. In terms of, again, histopathology, is this going to look ugly? Is this going to be a lot of messed up nuclei? And is this going to be like a really invasive? It doesn't look very good. Again, this is kind of like the way how it progresses. KRAS mutations are very important initially, and then you have inactivations of P16, and eventually you have SMAD4 and BRCA2 and P53 inactivation, all leading to invasive carcinoma. Your tumor markers are going to be CAA, CEA, and CA19-9. These are not used for screening, but they're good for to track. So let's say you have a patient with pancreatic cancer, you treat them with like a surgery, and then you keep measuring their CA19-9, and it's low, low, low. Then suddenly it starts going up. You're thinking of some sort of recurrence, and then this becomes like a really heartbreaking kind of like discussion in the clinic. Now, what about pancreatic cysts? In the stomach, we had gastric polyps, right? And we had to rule out whether they were like bad or good. In the stomach and in the intestine, we had those polyps, those non-neoplastic and neoplastic. In the pancreas, we have pancreatic cysts because they could mimic cancer, and we have to make sure that they are not. There are two types of pancreatic cysts you should know. One of them is serous, one of them is mucinous. So serous cystadenoma and mucinous cystadenoma. In serous cystadenoma, the lining is cuboidal epithelium. They usually found in the body or the tail of the pancreas, and when you drain them, they are very straw-colored. This is an example of a serous cystadenoma. You can see there's a lot of kind of like cystic spaces, and they're filled with serous fluid. They're not filled with mucinous fluid. Mucinous cystadenoma, which has a higher malignancy rate, is filled with mucin. And again, it has a bit more of a malignant potential compared to serous cystadenoma. And this one is lined with columnar epithelium. The other one was with cuboidal. This one is with columnar. And when you look at it down there, you can see the columnar epithelium there. This has a slightly higher malignance. And again, usually they are maybe picked up incidentally, or they cause a bit of pain because they're found in the body and tail. Will they present with jaundice? No, because they're very, very far from the head. So going back to this question of this patient who's presenting with weight loss and big epigastric pain and blah, 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 and hyperbilirubinemia, this is very, very classic of a patient with adenocarcinoma, most likely in the head of the pancreas. So a pop quiz for you guys. You have a 65-year-old woman. She comes in with some like probably some pain on the epigastric region. You do a CT scan and you see a 8 centimeter mass in the tail of the pancreas. You take a biopsy and it's glycogen rich. It has cuboidal cells filled with clear fluid. What do you think this patient has? Yep, absolutely correct. It is actually F, serous adenoma. Usually you tell the lady she's 65, you don't really want to take her into a surgery. You tell her, listen, it has very low malignancy potential. We'll just watch and wait and see what's going on. Here's another patient. This is kind of like the imaging there. I'll come back to it in a bit. 58-year-old woman comes again with the same thing, mid-epigastric tenderness. You do a CT scan, I just showed it to you, and the cells show cytological and architectural atypia, but has no invasion of surrounding pancreatic parenchyma. And this is the CT scan. This is how it looks like. And they're asking you which of the following is the most likely diagnosis. Absolutely correct. It is a mucinous cystic neoplasm. Now, you could ask me, why is it not a pseudocyst? I mean, pseudocysts look big. The answer is number one, if you notice, this is multi-loculated. There's multiple chambers within, right? Pseudocysts tend to be one walled-off chamber filled up with the same necrotic debris. Secondly, this patient has no history of previous acute pancreatitis. Remember, pseudocyst is usually a complication of acute pancreatitis. Oops. This is the last section, so we're so close. I'm so proud of you guys for staying so long. Really, really, really proud and really happy. Do you have any questions so far? Okie dokie. I'm moving on now to the biliary tree. We have a single question on this section. This is a 45-year-old woman. She's coming in. She's like, yo, doc, listen, I've been itching for the past 7 months. And I don't know, my husband is telling me I can't look yellow. I don't know if it's just him. I think he needs new prescription glasses. You do a physical examination and you're like, oof, nah, she is actually kind of jaundiced. Obviously, you get all the labs. You see the bilirubin is 5.7 and the direct bilirubin is 4.6. So this is kind of like elevated, this direct hyperbili. You check the alkaline phosphatase, it's elevated, it's joint 21. But the liver enzymes are like kind of mild, they're mildly elevated. You do a liver biopsy and you see destruction of the portal tracts, loss of the bile ducts, and lymphocytic infiltration. The question is asking you which of the following is associated with the disease. So this is a second order question. So you have to know what's the diagnosis first and then find out what's associated with it. So whenever you have a middle-aged female and presenting with cholestasis, which is what this patient had, the ACL, LFTs were kind of mildly elevated, but mainly you had hyperbilirubinemia and increased alkaline phosphatase, and mainly complaining of pruritus. And the biopsy shows intrahepatic bile duct damage, so only affecting the bile duct in the liver, as well as a combination of anti-mitochondrial antibodies. This is very, very classic for primary biliary cholangitis. They usually won't show you this complete picture. They'll hide a few to make it a bit harder. But al-Muhim, we said this previously. If I see anti-mitochondrial, I know it's PBC. So if I see anti-smooth muscle, what do I have? Anti-smooth muscle antibodies. Let's see if anyone remembers. Ooh, so PBC is anti-mitochondrial. What about anti-smooth muscle? Yeah, so autoimmune hepatitis. So autoimmune hepatitis is going to be the one with anti-smooth muscle. Anti-mitochondrial is going to be your PBC. Now, when you look at it again, you'll see a granulomatous destruction of intrahepatic bile ducts. And it used to be called in your size primary biliary cirrhosis. They decided to change the name. So now it's primary biliary cholangitis. It's the same thing. And it will eventually lead into cirrhosis. Again, like we said earlier, these patients will present with fatigue and pruritus, and they'll have xanthomas and xanthelasmas. And most importantly, the anti-mitochondrial antibody is going to be positive. When you look at the biopsy, you're going to see granulomatous cholangitis. So you'll see the presence of granulomas, like the name suggests, and still I don't have anything more to say about it. But then there's also another condition which is kind of similar, also has destruction of the intra, but also the extrahepatic bile ducts, and that's primary sclerosing cholangitis. It's also due to an autoimmune destruction. However, it is not limited only to the liver, but for the entire biliary tree. Now, usually there's going to be some sort of history of IBD. This is very, very, very common with patients who have ulcerative colitis. In fact, if a patient with ulcerative colitis has also primary sclerosing cholangitis, they are at an even higher and higher risk of developing carcinoma. Anyway, these patients will present with IBD and cholestasis like in PBC. However, they have another very characteristic finding, which is beads on a string. They love to ask this every year. You guys should all try to get this question correct. They will show you this kind of very classical, there we go. This is the beads on a string appearance in MRCP. Again, it's very similar. Again, this is not going to be like this typical kind of like multiple like strictures and dilations. That's why you have that beads on a string appearance, and is associated with this very classical concentric fibrosis around the bile duct, also known as an onion skin appearance. So they love to test this, especially for pathology. So if you have an onion skin appearance and the patient has IBD and he has like that cholestatic picture, I'm thinking of primary sclerosing cholangitis. Again, this is the beads on the string. They love to ask this. And again, going back to our question, in this patient who's presenting with destruction of portal tracts and nasal bile ducts and lymphocytic infiltrations. And again, this is most likely going to be associated with anti-smooth anti-mitochondrial antibody. In patients with PSC, they are associated with ANCA antibodies, so anti-neutrophilic cytoplasmic, I don't know, something like that, but they're associated with P-ANCA antibodies. So again, just to kind of recap, anti-smooth muscle, autoimmune hepatitis, anti-mitochondrial, PBC. ANCA positive is going to be primary sclerosing cholangitis. Here's another question for you guys. This is a 43-year-old man. He has progressive fatigue and pruritus and icterus for the past 4 months. He is a known case of ulcerative colitis, now presenting with generalized jaundice. He has a cholestatic picture, increased serum alkaline phosphatase, and he has increase in ANCA antibodies. And okay, MRCP shows intrahepatic biliary tree obturation and beaded appearance. And they're asking you which of the following is the most likely corresponding histological pattern. Okay, let me ask you all a question. What is C? Granulomatous bile duct destruction. What pathology is associated with granulomatous bile duct destruction? I'm gonna go back a few slides. I'm not gonna say anything. I'm gonna go back a few slides to show you this one nice picture. PBC is associated with granulomatous destruction, granulomas in the bile ducts, and they will start destroying the bile ducts. So option number, where is it? Option number C is corresponding to PBC. This patient has PSC. So like you guys said, the correct answer is concentric onion skin appearance. And whoa, we are finally done. Thank you so much for listening. This is kind of like a wrap up on GI pathology. If you have any questions, do let me know. And yeah, it's a bit of a little kind of like rushed a little bit, but hopefully you guys find this kind of helpful.